Good morning, everyone. I guess I need to get closer. I'm Suzanne, and I'm with the Epilepsy Foundation of Arizona. I'd like to welcome you all to our seminar today. I'd like to thank our sponsors, who we wouldn't be able to do this without them, and they are UCB, LivaNova, Upshur Smith, Supernus, and Lundbeck. Thank you very much for them. And I would like to introduce our new program manager. She started with us in November, so those of you who know us, there's only two of us, me and Min. And she's sitting in the back, and I think you met her when you signed in today. For those of you who don't know, the bathrooms are just to the right and then to the left. And it's wonderful that we have this every year with the Phoenix Children's Hospital, because I think that it's valuable for parents to know about the different types of epilepsy, what's coming up, and any news regarding epilepsy and any of the medications or devices that are coming up. Because you don't have time to speak with your doctors about that during your visits with them. We'd like to really thank the doctors today who will be speaking to you, because it is their private time and it is spring break, so I think some of them are here and they could be elsewhere. So thank you very much, Dr. Kerrigan, Dr. Williams, who's here right now. Just for your information, those of you who have children ages 8 through 17, we have a camp, and it's going to be for, this year it's going to be June 5th through the 11th, and it's in Prescott. And the qualifications are that the child needs to be able to dress and take a shower, be able to take care of themselves. Other than that, they have to have epilepsy. And it's a great camp. We have scholarships for those who can't afford it, and we do encourage you to go to our website. We have flyers out on our table, and consider your child participating, because it really is a great camp, and it's the first time that a lot of the children are able to meet other children with epilepsy, the same type of seizures, and they also have great role models in the counselors, because the majority of the counselors have epilepsy and they're going to college and they're succeeding. And Dr. Williams will be there, I hope, again, as our epileptologist, and we have nurses there to take care of all of the needs of the medical needs of the children. So we hope you go there. And we also have a new support group in the East Valley for those who live in Gilbert Chandler area. It's at the IHOP on Baseline and Power Road. And it's the second Thursday of the month at 6:30. So we're trying to promote that for parents of children as well as adults to attend who in the East Valley, because we haven't had a support group in that area in quite some time. And the other support group for children with intractable epilepsy is at the Harvest of Tempe, and that is in Tempe on the second Saturday of the month at 2 p.m. So thank you very much for coming, and let me introduce Dr. Kerrigan.
Thank you, Suzanne. All of you for coming today. It's a beautiful day. I know that there's other things that everybody could be doing, but we do appreciate the fact that all of you here have a passion about this particular topic. I know that some of you are complete newbies to learning about this, and for those of you, the learning curve is rather steep. I also know that there are some veteran families here who know a lot about the condition, and hopefully there's something here for you as well. I'm going to do an overview topic that really would be sort of Epilepsy 101 for parents and families who are new to it. The other topics today, Dr. Williams is going to be talking about emergency management of seizures, which is a very important issue, both in terms of perhaps preventing that as well as treating it when it happens. Dr. Maris is going to be talking about some of the cognitive learning and memory issues that go along with epilepsy and the things that we do to treat epilepsy. And then Dr. Adelson is going to be finishing up the morning with a talk on epilepsy surgery. So hopefully there'll be something there for everybody. This is something that we do annually. It's a relatively small community of doctors that work in this field here in the Valley, but we try to kind of sprinkle around the speakers and the topics year to year. So next year, hopefully you'll attend again, and it'll be a little bit of a different lineup of speakers and topics. So to start today, this is an overview. This is going to hopefully get kind of the big picture, shall we say, at a rather superficial level. We do have about 5 or 10 minutes for questions at the end if this brings up something that you want to ask about a little bit further. So real basic stuff. What is a seizure? A seizure is an electrical discharge of the brain. So basically nerve cells act abnormally in a sense that they fire repetitively in one part of the brain or the other. And that results in diverse symptoms depending upon which part of the brain is affected. So I think everybody can relate to the idea that we have visual areas in the brain, language areas, motor areas, some areas that are important for things like short-term memory and even emotion. And depending upon what part of the brain is involved, if you're having a focal seizure, then the symptoms or what you would see with your child relates to that part of the brain. A lot of times families will ask, why do seizures occur, or, what is it that's really happening? And there's really two very simple, basic concepts that relate to every conceivable type of seizure. And these are the two concepts that I'm going to show in the next two slides. Everything after that is all about the details, okay? But these two things have to be occurring in order for a seizure to happen. The first one, and the one that gets talked about most commonly, is that there's an imbalance to excitation and inhibition, okay? So your brain basically is working every single second when you're awake, when you're asleep, with gazillions of synaptic connections, which are electrical events that occur between electrical and chemical events that occur between one nerve cell and the other. And so your brain is always very, very active. If you tip the balance towards excitation, you're going to be prone to seizures. If you tip the balance towards inhibition, you're going to be prone to coma. You're not going to be waking up and you're not going to be functioning. And your brain really does a very exquisite, a very elegant job of maintaining that balance most of the time. For people who have epilepsy, that balance tips from time to time and they would go into a seizure event. So the kind of things that would cause epilepsy would be potentially too much excitation or something happens with the brain that causes too little inhibition and those scales tip. So it could be adding something to the excitation side or taking something away from the inhibition side. The other thing that has to occur that gets talked about a little bit less often is that it's not enough for nerve cells to be overly excitable, but they have to fire together, okay? And that's the activity that then would result in a seizure activity, so seizure event. So basically, these two things are always required. Everything else after that is the details that often relate to molecular or genetic types of issues. This is the only slide that I'm going to show that really kind of drills down on the biology. Here we have one of the major principal neurons in the brain, in the cortex. It's called a pyramidal neuron. It's got a little bit of a pyramid shape to the cell body. And these are the cells that ultimately have to get involved to give rise to a seizure. If we study that cell in various experimental kind of platforms, we can see that it's overly excitable, so that this cell is bursting. You can kind of expand that a little bit here and see that it's firing in a repetitive way, which a cell behaving normally would not. Typically, it would fire once. This particular cell here, which is involved in an epileptic circuit, is prone to burst firing. And that's kind of the signature that we look at for cells that are overly active. We can also kind of visualize seizures as well. And basically, if you have a focal seizure, then that region of the brain is overactive, We've talked about the overexcitation and the synchrony, so there's too much activity happening in that particular part of the brain. And if we do an imaging study that looks at brain activity rather than a brain structure, and this is a PET scan that does that, so this is the brain taking up glucose, which is the fuel for the brain, we can see that this youngster here is having a focal seizure from way up in the frontal region here. This is a colorized version of exactly what's seen here on the bottom. I think everybody relates to the idea that brain scans take pictures in different planes, and these are the three different planes that are each visualizing overactivity, hyperexcitability up in the frontal region here. So under some circumstances, we actually can get a visual for what a seizure looks like and where in the brain it might be occurring. So what is epilepsy? So epilepsy, the current definition, and this is the kind of thing that people in the field spend a lot of time kind of debating back and forth about nuances of single words. But basically, it's an enduring tendency to experience seizures. Okay? So febrile convulsions in an infant are related to the fever, not relating to an enduring tendency to have seizures over and over again in an unprovoked fashion. Alcohol withdrawal seizures in adult patients would be an example of something that we usually don't call epilepsy. If you stay away from the alcohol, then you don't have epilepsy. So epilepsy is a condition, there's something going on that gives you an ongoing tendency to have seizures. And of course, for some people, they have them all the time. For other people, they can be quite rare. For a lot of people, they can be, well controlled. Epilepsy and seizure disorder really do mean exactly the same thing. A lot of times that's confusing for families when they first start off, but those two words really do mean the same thing. Some families may prefer one term over the other, but the meaning is the same. So when do patients get epilepsy? Well, it turns out that the childhood age range is one of the periods in life when epilepsy is most likely to occur. So this is an incidence curve, which means the likelihood of a new patient coming in the door with seizures versus age here below in decades. And we can see that in the childhood age range, here we're from 1 to 10 or 0 to 10, we can see that this curve is very steep. So kids are highly prone or more likely to develop seizures as a new problem, whereas in the relatively healthy middle decades here, the new diagnosis of epilepsy is relatively low. It then begins to come up as we advance into our older years because older people acquire problems like stroke, tumors, dementing diseases, and things like that that also are related to epilepsy. The prevalence is the number of people in the population that have a particular condition. This curve is going up as these patients develop the problem. Then roughly about 0.5% of the population, roughly about 1 out of 200 people have epilepsy, which is the number that you see that's used most commonly. And this is where that number comes from, 0.5% through these years here. The prevalence actually begins to increase as we get into the elderly age range. So how common is epilepsy relative to some of the other things that kids are prone to? And this is just a slide to give you a little sense of perspective on that. Epilepsy 0.5, this particular slide has 0.6%, 1 out of 200. Febrile seizures, 5% of all kids will have a febrile convulsion, 1 out of 20. So 10 times as common as having epilepsy. Most of those kids grow up and they're fine and they don't have a lot of downstream issues. Compared to some very common pediatric illnesses like asthma, or contrasted here to insulin-dependent diabetes, which is 1/3 as common as epilepsy, though also a condition that people can relate to and perhaps know somebody who has that. We have two different classification systems for the patients that we deal with. One is a classification system that relates to the seizure event itself. And then on the next slide, which I'll get to in a moment, we have a classification system for patients with epilepsy. But first of all, speaking about the seizure classification, basically this relates to a single event. And the world of seizure events basically is broken down into two flavors. One flavor is a focal, sometimes called partial, sometimes called localization-related epilepsy. Basically, seizures are arising from a certain region of the brain. I used to say spot, but that gives people the mental image sometimes of a very little tiny, tiny area, and it's usually not quite like that. Usually it is a region of the brain. It's simple partial if the child has a seizure but maintains their awareness of what's going on around them. It is a complex partial if there is some alteration of their awareness of their surroundings. The way that we usually kind of define that is, can the child remember a test word that they're given during the seizure? So during the seizure, we'll say something like purple elephant, and then afterwards ask them, what did I say to you? And if they can give back that test word, then we would call that a simple partial seizure because they would be aware of what's going on. Secondarily generalized means a focal seizure that spreads into a grand mal seizure or a generalized tonic-clonic seizure. The other flavor is the category of generalized seizures. So basically these are seizure events that start on both sides of the brain at the same instant. Okay? It's not necessarily identical activity everywhere in the brain, but it is bilateral at the same moment. And here we're kind of descriptive about what they look like. Absence means your staring seizure. Tonic means stiff. Atonic means a loss of tone, often maybe with a collapse to the floor. We sometimes will call those kinds of seizures drop attacks. Tonic-clonic is the grand mal convulsion where patients get stiff and then go into a jerking phase. Now the other classification system, and these are complementary, so both can apply to any individual patient. Epilepsy syndrome classification is talking about a person or a child or a teenager, and it includes all the information about them. So how old are they when they presented with their seizures? Different forms of epilepsy relate to different age groups. When Dr. Williams or myself walk into a room to meet a new patient and we instantly see how old the patient is, we can instantly begin to kind of drill down a little bit on what kind of epilepsy that youngster may have. It's a different list for the infant who's in mom's arms or the teenager who's sitting on the edge of the examination table. It brings in a lot of other factors. The technical term is comorbidity. So what are some of the other neurological issues that the child may have, like cerebral palsy, intellectual disability, things of that sort. EEG pattern, what's the natural history? Is it one of the epilepsy conditions that kids do grow out of, where we can predict that with high confidence, or is it one of the conditions that we know will be a lifelong epilepsy? So all these things do come together. We want to understand the event, but also, of course, we want to understand the patient. Patients with certain epilepsy syndromes can have more than one seizure type. Okay? So that's where those things are kind of complementary and work together. For kids that have Lennox-Gastaut syndrome, which is one of our more common, difficult to control epilepsies, it's very common, it's expected, actually usually, that they would have more than one seizure type. So how do we go about the process of evaluating a new patient who has come in who is likely to have epilepsy? The starting point really is with the history. The process that we go through for this is to try to have the parent, typically it's one of the parents, of course, who are providing this history for us, to try to give us sufficient detail that we can actually kind of mentally recreate what it looked like. In other words, I'm going to try to visualize what the event looked like by your describing it to me in sufficient detail. And that takes a little bit of time. But typically, if I can kind of get that mental image, I will know what kind of a seizure it was. Sometimes I may recognize that it wasn't a seizure at all. I certainly see kids that have fainting or breath-holding spells or other, kinds of things like that. But very commonly, I can see that visual image of a child that did have a seizure, and we're off to a pretty good start in terms of knowing what kind of seizure that was. What other kinds of issues are going on for that particular child? What is their past history in terms of having had trauma, infection, a difficult delivery and a difficult birth, other factors about them that would go along with a genetic syndrome of some kind, and the family history. So, of course, some forms of epilepsy are highly likely to run in the family, others not at all. The physical exam is important in terms of the, shall I say, kind of the clues that we would look for on a physical exam that would help us understand the patient. One of the studies that we will usually do, and I think I would say that you probably should expect this to get done in terms of evaluating your child, and then from time to time going forward, depending upon how things are going, we don't have any rules that say that an EEG has to be done every year or annually or anything of that sort. We tend to do them when we need them to answer a question. So if things are not going the way that we thought that they were supposed to go, not responding to treatment, a question like, is this a good time to take my child off medications? Those are the kind of issues where an EEG can be helpful as a helpful test. It very rarely makes the decision all by itself. Okay, but it is a useful tool, and for some questions, it's the best tool that we have. I just have 3 slides here of EEGs, just as a little bit of eye candy, just to sort of kind of know what they look like. Blue is on the left side of the brain. Red is on the right side of the brain. The way that we typically look at these is these are the electrodes that are up over the front, and then would go back to the occipital region or the back part of the brain, and then we just have chains that go front to back, and sometimes this is called the double banana montage in terms of looking at things. This pattern back here is a normal pattern for patients who are awake with their eyes closed. Basically, your visual cortex, which is in the occipital region here in the back, goes into an idling mode, like your engine does when you stop at a red light. Goes into an idling mode that we can actually see on the EEG. So this is normal idling of the visual cortex. This sort of stuff up here is eye blink. So this EEG, even though this child did have a seizure, this particular EEG is perfectly normal. So there are normal features that we're looking for when we read these. This EEG looks quite a bit different. So this would be the EEG signature for a youngster who has a focal or partial or regional form of epilepsy. Seizures are beginning from a particular place in the brain. So here, these are epileptic spikes, also called epileptiform discharges, sharp waves. There's a number of different terms that we use. And these are located basically in the central region here on the right side, just above your ear, which gives us a very compelling clue that, yes, indeed, the history is consistent with the EEG finding, and also for us, a sense of where in the brain the seizures may be coming from. Contrast this EEG with this one, which would be a generalized discharge. This is a little girl who just recently started to have absence or staring seizures. This is what we would talk about as a generalized discharge. It really doesn't matter too much which of these various channels or which of these various lines that we're looking at, because this activity is really distributed all across the board. Like most generalized epilepsies, it's a little bit more developed over the front of the brain compared to the back as you look at each of these chains. So it's the frontal region here rather than the back, but it is the same on both sides. So this would be the EEG signature of a generalized epilepsy.
So it's happening on both hemispheres?
Correct. If you have a generalized epilepsy, you're having a seizure event that's happening on both sides, both hemispheres. The other kind of testing that we do, and I'm just showing a single slide here just really as an example, the other kind of testing that we do is imaging. This happens to be one of those areas where we have made a lot of really revolutionary progress even during the course of my career. So there was a day when we literally had x-rays that we would do of the brain. CAT scans came in the late 70s. MRI scans really got popularized in the early 90s. You know, this is really just going back 20 or 25 years. And the technology here really does still improve incrementally each year, okay? So our ability to find abnormalities in the brain does get incrementally a little bit better. So this is an example of a space or a niche where we really have made a lot of progress over the last couple of decades. Many patients with epilepsy, particularly many patients that have generalized epilepsy, will have perfectly normal MRI scans. Patients that have focal epilepsy may or may not have something that we can see on the scan that would relate to the cause of the seizures. Okay? And then we're into a lot of detail and a lot of nuance. This particular example here, there's a bright spot that we can see on the MRI scan right in this region here. That at first glance would be something that we would think of as perhaps a focal cortical dysplasia, a small region where development did not go quite right. Alternatively, that's something that could be a low-grade tumor and needs to be kind of watched and kept an eye on in terms of how that's going to go. But for this particular patient, the EEG localized with spike activity to this region, and indeed the MRI scan, gave us a culprit, if you will, in terms of why the seizures were occurring. I also want to make the point that on EEG, when we say that the EEG has spikes, that's not the same thing as saying that the EEG has seizures. Okay? The seizure is the event, the EEG pattern, when your child has his or her spell. Spikes that we see on an EEG between seizures is a clue or a marker or a diagnostic test, but not a seizure itself. And that's something that I have found always causes a little bit of confusion for parents who are new to it. So this gives us the testing that we do, the history, the physical exam, EEG, MRI scan, sometimes some additional testing as well, basically does give us some kind of a broad path to follow. This is an extremely simplified version of that path. But for the child who has had a single seizure, we go through the workup that we just mentioned. If we discover that the EEG is normal and that the MRI is normal and basically everything is kind of reassuring, we will typically not recommend starting an everyday anti-seizure medication. We might recommend having a safety medication in the event of an additional seizure, but the majority of those patients will not have a second seizure. The statistics are pretty good that there won't be a second event. If we do the workup and we find abnormalities, we know that we have a child that has CP for one reason or another. We find something on the MRI scan. The EEG shows us a lot of the interictal spike activity that we talked about before. Then we will maybe or likely recommend that we go ahead and start with medication. That's always a decision that's made as a partnership with parents. Some parents are, shall I say, kind of traumatized by the seizure event. They'd like to really not see it occur again. Other parents, have their own thoughts about whether they like to have their kids on prescription medications or not. So this is a dialogue that we have with the family. If there's a single seizure event, there's always a space for discussion about whether this is a good time or not. And families do lean in both directions. If we have two or more seizures, which is kind of the conventional old-fashioned way of diagnosing epilepsy, two or more seizures, then typically we are going to make that diagnosis, and under most circumstances we're going to recommend a treatment for that. There are always exceptions, and these are the kind of things that we work out with office visits. So it's a crowded landscape today for seizure medications. So this is largely how I spend my professional day, is looking at this menu of options and talking to families about what might be recommended. This slide is not exhaustive. There's kind of a good news, bad news story here. We are very grateful for having all these different medication options to treat kids that have epilepsy. It is always good to have something else to try if the first or the second medication isn't working. The flip side, though, is that it's also true that none of the compounds, none of the medications that you see on the slide has put the other ones out of business. Okay? So none of these medications has proven itself to be so superior that the other guys just disappear. That obviously hasn't happened. And in fact, there's now too many medications for me to even put on the one slide, so I've kind of spilled over to a second slide. And this is an area where we are still getting new developments. So this medication right down here, brivaracetam, actually came out, exactly 1 month ago. So this is now a medication that's on the market. It is FDA approved for treating focal seizures in patients who are 16 years and above. I have not yet personally written a prescription for this medication, but for those of us who treat kids, we are often in the situation of using medications off-label because the studies simply haven't been done in children. And if we think we have a good medication on our hands for treating teenagers, we will usually also begin to use it in younger kids as well. But this is, we do have a pipeline of medications that are coming through and will continue to come through. And as each gets approved, we then begin to get real life experience with it, and it finds its niche, usually over the first 5 or 10 years that it's out there. Each of these medications, has its own personality, and that personality often reflects itself in terms of the side effect profile, as well as the types of seizures that we might want to use for it. Again, part of my job is to walk down this path with families in terms of, okay, there's a couple of options here. One may be preferable for one family or for one patient over another. In 1991, which is when I started with my career in pediatric epilepsy, this was the landscape for the medications that we have. Here we are looking at the world broken down by seizure type. So focal seizures here, generalized seizures here. We had a small list of medications. These are the Tegratols and the Dilantins of the world that were good for focal seizures. A couple of niche medications down here. Ethosuximide is Zorontin. And really just one medication that was good for broad spectrum use, meaning good for all the different seizure types, and that was valproic acid and Depakote. And this is another area where we have had a lot of progress over the past 25 years. So the newest medications are listed here in white. The brivaracetam, again, just came out last month. So we are blessed with a large number of additional choices, particularly medications that we would consider to be broad spectrum, good for all of the different seizure types, good for the generalized epilepsies, which are particularly common in children. We're very blessed with this kind of an outlook, but the flip side, though, is that no one of these medications has put any of the others completely out of business. I just wanted to talk about a couple of very introductory comments about how we use these medications, because I think parents are very much empowered and very much ahead of the conversation if you kind of know these concepts. There is something called the dose-response curve, and that's a very general concept in terms of treating conditions with medications. It's not something that just applies to epilepsy, but it applies to most things that we treat. But basically, a greater likelihood of a response here and going up on the dose here, so that gives rise to this curve. So the higher you go with the dose, the more likely you are to get the response that you're looking for. So the usual approach that we use is to start with a low dose and then work it up according to how the child is doing. Many patients will be controlled with that first drug at a low dose. Everybody's happy about that. For a lot of families where the child struggles with seizure control, we work through the dose-response curve with each of the medications that we try. The corollary to this is the blood level. Now, it is true that the doctor often is ordering blood levels, and a lot of times families will be scratching their heads about, it's a lot to put my child through a blood draw. Why do we have to kind of do this all the time? Well, what we're doing is we're watching that dose-response curve, because as the dose goes up, the blood level goes up. A particular dose in any individual patient could result in a low level or a high level based upon how they metabolize medications, and all that stuff is rather unique person to person. So knowing the dose is important, but knowing the blood level is often even more important, because that gets us one step closer to the action. Okay? The blood level is the physical amount of the medication that's contained in the bloodstream. This is another kind of basic concept that I think it's useful for families to have, and this is the concept of the peak and trough effect. So when you take a medication, and again, this is not unique to seizure medications, but it certainly applies to them. When you take a medication, your blood level goes up. It's absorbed from your stomach, hits the bloodstream, your blood level goes up, and we get what we would call the peak effect. Then as the hours go by and your liver metabolizes the medication or your kidneys excrete the medication, that level will go down, leading to a trough, and then you take your next dose. Okay? So this is happening constantly for anybody who's on a medication. At the peak, you're more likely to have good seizure control, but also more likely to have possible side effects, the dose-related side effects that go along with these medications. At the trough, you're going to be statistically more likely to have seizures. Doesn't mean that you'll have one every time, of course, because you're doing this every day, but statistically that's where seizures are more likely to occur. So this short discussion is to make sure that you're aware of those concepts, because the doctors will often talk about peak and trough type issues. And also to make a little bit of a pitch for the extended release formulations, the slow release formulations that will help avoid those swings. Okay? And many of the medications that we have today have those formulations. So here, now we're taking the medication twice a day. There's 2 peaks rather than 3 over this 24-hour period. But because it's a slower release, the peak is not quite as high. The child's perhaps less likely to have those dose-related side effects, and the trough is not so low, meaning perhaps less likely to have seizures. Okay? So this is, again, one of those things that's kind of basic blocking and tackling. If you haven't had this conversation with your epilepsy specialist or your neurologist, I would encourage you to do that, because there are a lot of extended release or slow release forms for the medications that we use. Now, the flip side to the dose-response curve is that there is also a dose side effect curve. And usually it's a pretty shallow curve at the very low doses, but as you get into higher doses, you get more and more likely to run into side effects. My child is walking around like a drunken sailor, or, falls asleep at the table, kind of thing, can't stay awake in school, issues of that sort. That eventually we will run into. So this, of course, is why we like to start with a lower dose and then work it up. Okay? Eventually, we will, for many kids, begin to explore this area, and that's where the doctor needs to alert you that, hey, we're getting to a higher dose. We know that we're getting to a higher level. We want to push it just a little bit more, and then as parents, you're being vigilant for a change in your child's well-being or behavior or whatever. Those dose-related side effects, basically side effects with medications, I find, quite honestly, that parents spend way too much time worrying about medication side effects. They are really important, but it's sometimes for a lot of families that's the beginning and the end of any conversation about the medications. They are real. They come in 2 flavors or 2 kind of categories. One category is dose-related. That is, my child's taking too much of that particular medication. We kind of talked about some of those issues already. And that can result in, these kinds of issues here, which can include things like double vision and ataxia, the walking like a drunken sailor kind of an effect. Dr. Maris is going to be really kind of drilling down quite a bit on this topic later when she's talking about learning and memory issues and concentration and attention and things of that sort. These kind of things happen if the dose is too high. We lower the dose, these things go away. Okay? It's a little bit like having too many cocktails at the cocktail party. You're not functioning well when you've had those too many cocktails, but they do go away and you're back to your normal self. The other kind of side effect is an unlucky bad reaction, and I don't have time today to kind of walk through that whole universe of things that can happen, but these are usually things that are uncommon and not likely to occur. For a lot of you in the audience whose kids have been on multiple medications, you know that eventually you run into stuff like this. But it's something that you need to be aware of, vigilant for, but I would say I don't want you to be overly anxious about these kinds of things. Here's an example here. The medications do differ in their likelihood of causing this particular problem here, which is allergic drug rash. So some of the medications, and lamotrigine is the single most notorious in this category, we really need to keep a close eye on. We really need to make sure that families are educated. They're aware that if it's a problem, we need you to stop that medication and call. But there are other medications where it just really doesn't come up, and it's not something that we need to spend a lot of time about. This same kind of a discussion applies to any of those significant unlucky bad reactions, like a liver reaction, kidney reaction, and whatever. I'm now kind of into the final lap here with my overview talk. We also have to recognize that sometimes medications don't work. And when do we need to begin to think outside the box a little bit in terms of other alternative things that we can do? And how do we kind of approach that decision? This is a study that was done now a few years ago, but is still kind of the most widely quoted study to look at this issue. This was a highly competent epilepsy clinic where patients were carefully evaluated and put on the medication that should have been the best one for them. And then basically it's a simple study, it's an observational study. It looked at, well, what was the experience of all these almost 500 patients. And this is what happened. So 47% of the patients, let's say half, were well controlled, side effect free on the first medication that they were started. That's fantastic for those 50% of patients. Everybody loves that. Okay? The flip side of that coin, of course, is that there were 53% of patients who weren't well controlled on the first medication that was chosen. So a second medication was then tried. And here we see the law of diminishing returns, which is to say that each new medication that gets tried, statistically, for the whole group, is a little bit less likely to work. Okay? And so basically we've kind of formulated, I used to use a 3-drug rule, and I'm kind of reluctant to give up on that, but my younger colleagues have embraced a 2-drug rule, which is to say if you've tried 2 of those medications and they were properly selected and used appropriately and kind of walked up the dose response curve, that's an indicator. That's the child telling you something, which is that I may be one of those patients that's more difficult to control, and let's give some thought to other alternatives, thinking outside the box. So Dr. Adelson, I just have these slides here as an extreme overview. Dr. Adelson is going to drill down on this quite a bit later this morning. When do we think about epilepsy surgery? There's 2 kind of real fundamental concepts here. One is that your seizures are not controlled. Alternatively, if you're just having to live with constant side effects of the medications in order to keep your seizures controlled. Usually it's not one or the other. Usually it's both of those things occurring together. But basically things are not going well with medication management. And for those fortunate patients, basically that the seizures are focal. They're coming from a place or a region. It's consistently always that place or region, and that place is a safe area to remove. Okay? So under those circumstances, we very definitely look at surgery as a first-line therapy, not an experimental approach. We've been doing epilepsy surgery for 60 or 70 years now, and it is something that we specialize in as a center. So we actually like to find this opportunity because it gives us a chance to really, shall I say, kind of hit the home run. There are alternative therapies for those who are not candidates for surgery. One of those is the vagal nerve stimulator. This is an electrical pacemaker that goes kind of under the clavicle here over on the left. Wires are placed up into the neck, under the skin, wrapped around the vagus nerve. And for reasons that we don't understand terribly well, intermittently giving that nerve a little bit of electrical stimulation helps reduce the number of seizures. Okay? So this is not a curative therapy, but rather a helpful therapy. A lot of families do like it because it's not a medication. So those dose-related medication side effects that we talked about earlier, which can add up if you're using 2 or 3 medications, this is kind of going in an alternative direction. Another alternative therapy is the ketogenic diet, which is something that we do specialize in here and use quite a bit. This is somewhat like a medication. So basically the ketogenic diet isn't quite like I'm going to get some added vitamins with my green leaf vegetables kind of thing. It's not, shall I say, healthy eating. But rather it's a rather radical diet that shifts your body chemistry into ketosis, okay? Which is a chemical environment that you weren't designed to walk around with, which is exactly what a medication is. It's a chemical environment you weren't designed to walk around with. So it has its own list of side effects, but it is effective, and it can be effective for patients who have failed our more conventional medications. And we get a little bit better with this every year in terms of having a dietary plan or a formula-driven plan that's an enjoyable way to eat in terms of how readily patients accept it. Here again, we kind of have the big overview. When we try our first medication, we're going to use that number that we had on an earlier slide. About half of the patients will be well controlled. We try a second medication or add a second medication, we're going to get another 13%. After that, as we walk through all the various medications, we're probably looking at a 3 to 5% likelihood of that patient coming under control. Now, that's not zero. And certainly it's a worthy effort to go through for kids that have difficult to control epilepsy, but the numbers do go down. They get to be, there's a law of diminishing returns that comes into play. Is the patient a candidate for surgical resection? If yes, then we actually like to find those opportunities. This is something that can be curative. For patients who are not candidates for resective surgery, and these are a lot of the frequent flyers in my clinic, and for those of us who do this kind of work, we're looking at whether other alternatives could be utilized, like the ketogenic diet, like the vagal nerve stimulator, or investigational medications that are being looked at by the pharmaceutical companies regularly to try to add to that list that we had talked about before. So that is a very broad overview. Certainly, when we talk about things like this, we have to kind of lump together large groups of patients. I think all of you know that your child or your loved one is unique, and the doctors really do recognize that as well, and not just because of age and stuff, but just where families are coming from and what's what might be important to one family isn't quite the same priority for another. So, so hopefully, thank you very much for your attention, and hopefully the rest of the day will also have some good content. And I think, Suzanne, do we have some time for questions? Yes.
Dr. Perry, I'm wondering if you could touch on any experiences you've had with medical cannabis. Because I noticed that was kind of missing.
Yeah, okay. So Dr. Traster at this forum actually did like a full talk on that a couple years ago, and I know that we will circle back to that topic because it's a hot topic with families. I don't want to say it's something that I discuss with every single family, but sometimes it feels like, we have that discussion 8 or 10 times a day. I probably, there is a major disconnect with regard to the law in terms of federal law versus state law. And most of us in today's world are employed physicians, so we have employers who kind of tell us what we're going to be doing and not doing. So for those of us who are employed by Phoenix Children's Hospital, we're not allowed to go there in terms of writing prescriptions for the marijuana, medical marijuana products, and there are many. Okay? Now, there certainly are providers who are out in the community who are engaged in that practice. And I probably have, I'm going to say 40 patients, maybe even closer to 50 patients who are using them. And again, it's a variety of providers, compound, dosing. It's always very individualized. I'd have to say that for me personally, I'm not yet very impressed with how well they're working. I am impressed that they seem to be well tolerated. Okay, so I don't see a lot of my kids getting sick or having problems with it. Likewise, I'm not, shall I say, blown away by how well it's working. It's a space, I'm giving you a little bit of a longer answer than maybe you wanted. It's a space where we really do need to put some science behind it. So there is now a trial, and we are hoping to initiate a trial here in the not too distant future that is really going to look at that in the appropriately scientific kind of way, meaning that initially patients are randomized to either the cannabidiol or the derivative, whatever product there might be, and a placebo for at least a short period of time. And the doctor doesn't know and the parents don't know, but you're maintaining a seizure diary. And the way that the science gets done, the way that it got done for every one of the medications that you saw up on that screen was just that way. So that way we can say that that they are proven to be effective and safe for most patients or for many patients. That doesn't mean that they're proven to be effective for every patient. Anyways, so we're on the cusp of actually doing those studies. So, and those studies do take time. I'm hoping that 3 years from now, 4 years from now, that we actually will have some science behind it and we'll know. I would love to find that they work, and I think that doctors in the field would say the same thing. We would love to have another option for treating our patients. Yes?
Can you talk about the effects of hormonal or metabolic effects on either drug effectiveness or seizure frequency? Do you find like the same dose of drug, if you go through hormonal fluctuations, that it is more or less effective?
A good question, but a complicated one. So we'd have to start drilling down on details about specific kinds of things. An example, though, that we really recognize, and this would be relevant for teenage girls and young women, is that there's a major influence of female hormones on the likelihood of seizures. So that would be the hormonal issue that I would deal with most likely on a daily basis. So when estrogens are high, and that's usually immediately before bleeding starts, seizures are more likely. Whereas progesterone is a relatively anti-seizure compound, anti-seizure hormone, so seizures commonly go down right away once bleeding has started because that's when the progesterones go really high. So that would be an example of hormonal influences having a major impact.
Have you done any kind of drug treatments that go through and fluctuate, for instance, Keppler levels throughout the cycle during
Yeah, I'm not aware that anything like that is really available to us right now. Keppra is an example that probably won't have that because Keppra is a medication that doesn't have a lot of binding or a lot of metabolism, but rather is excreted by the kidney. But that's an interesting question. But currently there's not anything that's kind of like on the market approved for us to use in that way. Yes? Yes and no. An example where it doesn't really need to build up in the system are the safety medications that we use, so like clonazepam dissolvable tablets. Okay, that's a situation your child's having too many seizures. It's a bad hair day with seizures, and you want to treat something to kind of really kind of dampen things down or put out the fire. So that would be an example of a medication that's given one time that has that effect. It reaches sufficient blood level and then brain level that it can have that effect. But other medications, a common medication to think about in the opposite way would be lamotrigine or Lamictal, where we start low and go slow, specifically to avoid the serious drug rash. And there's definitely a building up in the system kind of an idea that has to take place. Corwin, where are we with time? Good. Okay. So basically, I don't want to cut the other speakers short on their time. So why don't we go ahead and move on? I am going to stay for the morning, so folks are welcome to catch me between speakers or at the break. And again, thank you for being here. Our next speaker is Dr. Corwin Williams, who is a member of the Pediatric Epilepsy Group here at PCH. Dr. Williams has a particular interest in ICU monitoring and emergency treatment of epilepsy and is going to be speaking to us today on exactly that topic.
Thank you, Jack. Pardon me while I disappear for a second. Well, hello everyone, welcome. I want to thank first Dr. Kerrigan for a superb talk, giving you an overview about seizures and epilepsy. I think that if you're able to follow that and kind of take some of that information home, you probably know more than probably 90% of most physicians about epilepsy and management. I know it was a lot of information. And I think as one other quick aside, something I just learned myself today, we're talking about a lot of information, a lot of good questions are coming up, and given the nature of these talks, we're not going to be able to probably answer every single question that people have. But I just want to kind of point out something here at Phoenix Children's Hospital. We have something called the Emily Center, which is a library within the hospital. And what I just found out, if you were to go to the Phoenix Library website for the city of Phoenix, for the surrounding areas, that you can actually select Phoenix Children's Hospital or the Emily Center, and you can actually search the library here. So if you are looking for topics about epilepsy or special needs, you can actually look online and obtain stuff from our library in the same way you would from any other library branch. So that may be another resource for people to kind of keep in mind. Like I just found out about that just an hour or so ago. So anyway, my name is Corwin Williams. I'm wearing a couple of different hats today. I work here at Phoenix Children's Hospital at the Barrows Neuroscience Institute. I'm also an epileptologist, and I'm also a member of the board of the Epilepsy Foundation of Arizona, which is co-sponsoring this event with the Phoenix Children's Hospital. And I just want to kind of put a plug out. Suzanne mentioned some of the things that the foundation does, one of them being the summer camp for children with epilepsy between the ages of 8 and 17. There are lots of other things that we haven't talked about, such as Studio E. So I would also direct you all to the website for the Epilepsy Foundation of Arizona, epilepsyaz.org. I would also encourage you maybe to like them on Facebook, so when there are updates, your feed is also going to be notified about different events that may be of interest and relevance, such as the support groups, other conferences, and the like. Okay, so just think about that. But anyway, my talk today is going to be about epilepsy or emergency management of seizures. And I will be talking about an off-label use of one particular medication, but otherwise no other off-label uses will be discussed. I have a few goals for you all to keep in mind. This will be a lot of information, and once again, I kind of want you to think about this more as an overview, information that you find relevant to yourself. Otherwise, if you don't find it to be terribly relevant to yourself, don't worry too much about it. But I do want to go over briefly, touch on, because I always find repetition is a good idea. Dr. Kerrigan and I and Dr. Adelson certainly and Dr. Maris think about these concepts all the time, so for us it's almost reflexive when we talk about it. But some of you may have heard different phrases, different terms, and so I just want to redefine once again seizure and epilepsy very quickly. Dr. Kerrigan did a beautiful job discussing seizure types, so in the interest of time I'm probably moving very quickly through that. But as he pointed out, how we classify seizures also really determines how we manage them with daily medications. But particularly with relevance to this talk, I want to talk about seizures and status epilepticus and how commonly they occur. I see Suzanne moving closer. Bigger? Talk bigger? All right, I'm a soft talker. So anyway, also briefly review seizure first aid and then also outline medical treatment of prolonged seizures. Can everyone hear me? All right, good. Thank you. I would like for you to understand some of the risk factors for prolonged seizures. These are not going to apply to everybody, but for some, I want you also to be somewhat comfortable with seizure first aid and also be familiar with some of the treatment options for prolonged seizures outside of the hospital. Obviously, once you get to the hospital, the medical personnel will kind of take over from there. But what you do at home can also be very helpful as well. So once again, briefly defining seizure and epilepsy, and like I said, I'm not going to belabor this point. Dr. Kerrigan gave you one definition. There are a multitude of definitions. Neurologists like to use words. That's one. It's a manifestation of the hypersynchronous activity that Dr. Kerrigan mentioned to you, typically time limited, so it doesn't last forever, and it's due to abnormal neuronal activity. Now, there are lots of different ways of defining epilepsy, but here are some of the formal definitions that are in use right now. If you've had more than one unprovoked seizure, so not due to a fever, not due to a blow to the head, not due to low blood sugar, and is separated by more than 24 hours, then that's one way to define epilepsy. If you've had one seizure, but there is evidence, and that was getting to some of the testing Dr. Kerrigan was mentioning, that indicates that you have much better than a 50-50 chance of having another seizure in the next 10 years, that too can be classified as epilepsy. Now, as far as the incidence of a single seizure in children, whether you're looking at with fever and illness and the prevalence of epilepsy, let's talk a little bit about that. Some of this is really going to dovetail with what Dr. Kerrigan has already mentioned to you. About 25 to 40,000 children per year will have their first-time seizure. If we look at seizure in the context of an illness, maybe 2 to 4% of children will have one before the age of 5 years. And as Dr. Kerrigan already mentioned to you, the prevalence of epilepsy, the number of people with epilepsy is somewhere between 0.5, 0.7% in any given population. And here's that same slide that he showed you earlier, which is always kind of interesting. I always have a lot of families come in and say, like, well, I always hear that seizures go up when people go through adolescence. And it's like, no, not really. Actually, the most likely period for you to have a seizure and develop epilepsy is in the first year of life. And it progressively becomes less and less likely until you start getting into the older ages, at which point it starts going up for the reasons that Dr. Kerrigan already outlined. And as he mentioned to you, we have different types of seizures. I have slightly different nomenclature here as far as the non-convulsive ones, but really you can think about this as, well, a little bit of overlap. Some as the partial, some with the generalized, but also the convulsive, so the ones where you actually see motor movement of some type. Now, hopefully this is something that people who have experienced a seizure, had a family member or friend have a seizure, they are familiar with seizure first aid. The first thing we always want to do is make sure that they are safe. So if they're near the edge of a cliff, if they're in water, if they're in the middle of the street, get them to safety. If they're not already on the ground and they are unconscious, gently lower them to the ground. If they are not fully conscious and they are on the ground, put them on their side. Right, left, doesn't matter. The reason we do that is people may sometimes vomit before, during, or after a seizure. We don't want that going into their lungs where it can cause a nasty infection. We never put anything inside the teeth, and I'm going to emphasize inside the teeth because we will be putting something inside the lips, but I want to make sure we want to keep it outside of the teeth. The teeth, for all of us, are designed to chew, to break things. And even in young children, these are some of the strongest muscles in the body, so we really don't want to stick things inside of those teeth. Also, you activate 911 if the seizure is not ended within 3 to 5 minutes, but at any time, if you have concerns, you call 911. All right, so let's get a little bit more into this issue about emergency management. I think that really starts with this discussion of status epilepticus. Status epilepticus is a medical emergency. Traditionally, it has been defined as a seizure lasting more than 30 minutes, either a continuous seizure or a briefer seizure without recovery between episodes of seizure. So like I said, we like to use lots of different words, but those are two different ways of saying the same thing. Now, why do we choose 30 minutes? That seems like an awfully long time. I've had families who watched their children have a seizure for, say, 30 seconds. They felt it seemed like forever. So 30 minutes is just unbelievable. But where does that come from? Well, it really comes from some animal models looking at primates who showed evidence of irreversible brain injury if the seizure lasted more than 30 minutes. However, in practice, 5 minutes tends to be the cutoff where we're going to start intervening to try and stop the seizure. Now, where does this data come from? Well, some of this data comes from epilepsy monitoring units. For those who don't know, sometimes patients are brought into the hospital and monitored with continuous EEG for different reasons, answer different questions, but to look at seizures. But there have been studies looking at how long do people seize when they're in a monitored situation. And this is a particular example where they had many adults who had multiple seizures while they were in the epilepsy monitoring unit. And what you see here is really a graph. At the bottom you see a delineation of the different types of seizure that you're experiencing, where there was a secondarily generalized tonic-clonic seizure. Dr. Kerrigan mentioned the complex partial seizure. So different seizure types. And what you see along the ordinate, or the side one, the top one, the vertical line, are the number of seconds. So keep in mind, 60 seconds be 1 minute, 2 minutes, 3 minutes, 4, 5 minutes. You'll notice most of those dots, which are the duration of the seizures, are below that 300-second limit, so less than 5 minutes. And many of them really kind of cluster even less than 2 minutes. Now, there are a few outliers that you see here. But as you can see, the vast majority of the seizures did not last 5 minutes. So typically, seizures are self-limited events. But when you go to the 5-minute duration, you're already talking about an unusually long seizure that might or might not stop on its own. So here's another study looking at a smaller number of adults, and once again, their mean duration that they saw for the seizures was only about 60 seconds, the longest being a little bit less than 2 minutes. So this has led many experts to come up with an operational definition of status epilepticus, or in this case, impending status epilepticus, which says that if you have a seizure lasting more than 5 minutes, that we treat that as status epilepticus. The animal data, they said, was not fully convincing, that 30 minutes is the limit you have to get to before you see irreversible injury. We also know from a practical standpoint that when you start dealing with prolonged seizures, they become more difficult to stop, that you have to use more medications more aggressively, and sometimes you have to make use of other measures, whether or not you have to put people on breathing tubes or breathing machines because you have to support them because you have to be so aggressive with your anticonvulsant therapy. And also, we noticed that you can start to see changes in other vital sign parameters before 30 minutes. So we really don't want to wait 30 minutes to start treating seizures. Now, lots of different ways of classifying status epilepticus, and this really kind of goes back to some of the individual seizure types that we talked about. So you can have convulsive status epilepticus, which will either be a full body convulsion. You can also have sometimes just one limb moving, so maybe we'll have a partial motor seizure. You can also have non-convulsive status epilepticus. And maybe this, once again, may be a complex partial seizure, so a seizure type in which maybe there is not much in the way of obvious jerking or shaking, but the patient still is not fully alert and attentive and aware. So that's one type of complex partial status epilepticus. A less common type is something called absence seizures. Superficially, it may look very much like a complex partial status epilepticus, although the medical therapy used might be very different. And then sometimes you have just subtle status epilepticus, and the neurology literature is replete with instances of people who are a little confused, a lot of times more on the adult side, sometimes for days or weeks, and when you finally get around to getting an EEG, you find out they're seizing, and when you treat that, all of a sudden they become much better. So, now, as Dr. Kerrigan alluded to, sometimes when we deal with epilepsy, sometimes we find that not every epilepsy responds to traditional seizure medications. The same thing is true for status epilepticus. Sometimes they're very difficult to stop, and this is what we call medically refractory status epilepticus. In that case, maybe you've used two first-line agents, and the seizure still persists. Or if you've had a seizure that has been going on more than 1 hour. See some of your eyes raising at the hour limit. Sometimes they can go on for days. And that's when we start talking about something called super medically refractory status epilepticus. So sometimes you actually have people who are seizing not just for hours, but we're talking about days and weeks, and we are struggling with all of our medical management to try and control that. So that's only a very small proportion of status epilepticus, but it is a phenomenon that does exist. Okay. There's some other kind of odd ones, electrical status epilepticus in sleep. This does not have quite the same sort of prognostic significance as supermedically refractory status epilepticus. And there's something else called epilepsia partialis continuus, once in a very rare epilepsy syndrome. And so I won't talk too much more about that. So when we talk about status epilepticus, as I mentioned, this is a medical emergency because, yes, so if you can't hear me, please just raise your hand like this. Suzanne's doing it back in the room. I think she says raise the roof, but just let me know. So when we talk about status epilepticus, and I said it is a medical emergency, the reason why we consider it a medical emergency because there is an associated mortality with it. Now, once again, children are not small adults, as a truism we say in pediatrics, and that's certainly the case here. As you can see, the mortality in adults is higher than it is in pediatrics. It's about 20% in adults, and like many things, it really depends on why they had the status epilepticus in the first place. So if someone had status epilepticus because of a severe traumatic brain injury or they had a massive stroke, that certainly does not portend well for them surviving that. If they had status epilepticus because they forgot to take their evening dose of medication, usually not as associated with a high risk of mortality. And as I mentioned, for children, it's much lower. So maybe about 3% is that risk of death. And once again, it often really depends on why they had the status epilepticus and also whether or not they had any sort of conditions that predispose them to not being as healthy as other kids, which may also have been the reason why they have their epilepsy in the first place. So this was just a study out of England looking at some children who presented with status epilepticus. And you can see all the different types there. There's a lot of words there, but just quickly to summarize this, over half of these children were neurologically healthy, but you can take away from that almost half of them were not neurologically healthy. About half of these, a little bit more than half of these kids had a fever at the time. And of those who had fever, a small percentage had meningitis, okay, which is always a word when we have a fever and seizures, especially in young children. What they found in those who did have status epilepticus, about 16% were likely to have 16% had another episode of status epilepticus. And as we talked about a little bit earlier, as far as the mortality associated with it, it was fairly low. In this case, about 3%. And here are just some examples as to some of the other issues that surrounded those children. One had meningitis, another had an underlying metabolic problem, and others had some unexplained neurodegenerative condition. The largest risk factor for those having status epilepticus was age. So what we see once again, the younger you are, the more prone you are to having a prolonged seizure. And as you can see, as we start stepping up the ages of the different cohorts of patient, less and less common to come across prolonged seizures. And I'll kind of skip that slide. Here's another study looking in Virginia, kind of looking at the same issue, looking at adults and kids. About 58% did not have any history of epilepsy when they had their first prolonged seizure. And as you can see in this case, those who were much older, the elderly, so that opposite end of the spectrum, were a little bit more prone to having the status epilepticus, or enriched in the study. It's a busy slide, but what I just quickly want to kind of point out to you is just as far as the events, that you see kind of a recreation of that same curve that Dr. Kerrigan showed you, and I showed you earlier too, where if you are younger, higher, as you get older, less common, and as you get much older, you see that risk of seizures going back up again. And then the black bar represents the overall mortality, once again, lowest in kids and higher for the adults. Skip that. All right. So really just kind of a reframing as to why do people have the prolonged seizures? Well, particularly in pediatrics, as I just mentioned that first study, illness seemed to be the most common reason why people would have a prolonged seizure. But some of the other causes for people to have prolonged seizure, why we always talk so much about make sure you take your medicines, change in anticonvulsants, non-compliance or not taking the medicines, people who are being taken off of their medications. One thing that we don't talk a whole lot about because it really is uncommon, but sometimes it does occur, sometimes seizure medicines can aggravate seizures. So that's something to be aware of when you're starting a new medication to kind of keep an eye on. And it may not, you're not crazy. Sometimes some seizure medicines do make things a little bit worse. You need to let your treating provider know about that because you probably need to come off the medicine, and sometimes that may fix the problem, at least as far as the aggravation of the seizures. Sometimes if there are metabolic disturbances, that too can also lead to prolonged seizures. I think we all kind of realize if you have an infection of the brain, one of the potential consequences or symptoms of that is a seizure, and sometimes those can be prolonged. And then neurodegenerative conditions can be associated with it, as well as some of the others. And those are going to be a little bit less likely, a little bit less common. Trauma, however, not so uncommon, but yeah. Okay? But at least in kids, fever tends to be the most common reason why. And this is really a slide that really kind of says all that again, so we're going to skip it. And we'll skip that, because that says the same thing too. So fever, one thing we haven't touched on much, but I've kind of alluded to. So children who have prolonged seizures, for the most part, tend to be neurologically healthy. But one thing that we know that does predispose to seizures are people who have underlying neurological conditions. So if you have, say, underlying cerebral palsy, if you have intellectual disability, those are things that can predispose you to epilepsy. Those are things that can predispose you to having a prolonged seizure. The other issue that we also know is if you have low anticonvulsant levels. So that kind of gets back to making sure that you take your medication as prescribed. For adults, we'll see a slightly different list. Some of the same ones on there. Low anticonvulsant levels. Obviously, if you've had an underlying brain injury predisposing you to epilepsy, that can lead you to have seizures. And then cerebrovascular disease. So that's not something we see a whole lot in children as far as strokes, but for adults, that could be another reason why they might have prolonged seizures. You know, one thing that I found most interesting, though, is a look at how often we see status epilepticus. And there was a study looking at how commonly we do see status epilepticus. This is going back in the 90s. And for really unclear reasons, we were seeing declining numbers of people who were having prolonged status epilepticus. And these were just some of the rates. Once again, young kids were the highest. Older kids and young adults lower, and then once you start getting into the very older group, you start seeing an increase in status epilepticus. Once again, in a different study, but we're kind of seeing that same number, 10, 15% who've had a recurrence of it. This goes through some of the underlying conditions associated with it. Once again, these are really some of the issues that we've already talked about, so I'm not going to belabor that in this slide. I will mention some less common etiologies that we sometimes see here in the hospital, but these sometimes prove to be really hard to control as far as prolonged seizures. Autoimmune. So sometimes your immune system acts up, and that sometimes can drive seizures. And once again, sometimes these seizures can last for days, weeks, months. Those are just some of the lists of autoimmune conditions. Sometimes you can have inborn errors of metabolism or mitochondrial problems. So once again, another type of genetic/metabolic problem that can lead to difficult to control seizures, toxins rarely, sometimes atypical infections. Okay. So how do people do if they've had a bout of status epilepticus? So this was a study looking at about 500 children who had presented with that. They found about a 10% risk of status epilepticus in this group. They found a little bit higher number, so they found about 30% of those had a recurrence of their status epilepticus, which they found to be most common in the next 3 months after their initial presentation. And I have here just some of the other numbers, some of the other groups. So this is why sometimes we do these studies, because one study usually is not going to be definitive, and you see this range. But I think the numbers are kind of, you know, in the ballpark of one another, so you get some idea about how often this recurs. Of those who had had status epilepticus, a significant minority had less than 1 year of seizure freedom, less than 5 years later. So sometimes this might indicate a marker of someone who has difficult to control seizures. And once again, there wasn't a statistical difference between those who had never experienced status epilepticus. So in this case, the lower number says that a smaller percentage of them had less than a year, so they had gone longer without seizures. So different, not enough patients in this, and not a big enough difference to say this is statistically significant, but it was getting pretty close to being a significantly different outcome. What about from a functional standpoint? And most of the studies come from adults, and they're looking at people who had had status epilepticus. And what they have here is the people and what level of disability they had before they had status epilepticus, so pre-status epilepticus, and their level of disability post-status epilepticus. And you can see going from none to people who were pretty severely impaired. They were in a vegetative state. And what you see is that for some people, they're able to kind of maintain their same functional status. But as you can see, for some, they actually did die in the course of their status epilepticus. Now, once again, this is adult data. We have to be a little careful about adults and kids. I think as pediatricians, we tend to find kids to be a little bit more resilient than adults, but just something to kind of bear in mind. So about a quarter of these adults in this group experience decrease in functional status following their episodes of status epilepticus. Some of the predictors for this decrease in functional disability had to do with how long they were in the hospital, which may be a marker of how sick they were, how difficult it was to control the seizures, whether or not the seizure was due to a recent cause, so whether it was due to, say, a recent injury to the brain, a stroke, meningitis, trauma. The other issue, and I think probably the one that I really want to kind of highlight this, is delay in treatment. Because as I mentioned earlier, we sometimes find it easier to stop prolonged seizures the earlier we try to intervene. Okay. So this was an instance of which they enrolled patients or adults who had status epilepticus. These are the ones who had that refractory one. So we tried a couple of first-line therapies to try and stop the seizures, and it still continued. And of those who had had refractory status epilepsy, these are the ones who were very, very difficult to control. A little bit less than, or about a fifth of them returned back to their baseline, compared to more than half of those who were able to have their episode of status epilepticus controlled fairly easily. So once again, severity of how impaired they were or how much their consciousness was impaired was a predictor of functional disability, and also if this was a first-time event, were also predictors of refractory epilepsy. Okay. So brief conclusion for this section. Status epilepticus can occur in anyone. It certainly can occur in those with epilepsy, but as we mentioned, it also can occur in those without epilepsy. Most seizures do not last 5 minutes, so if you have a seizure that's prolonged, we would like to intervene. Seizures lasting more than 5 minutes warrant the treatment, and it's not always convulsive, so you have to keep a high level of suspicion in cases of people who are not fully there. All right. I'm just going to briefly mention that when we talk about prolonged seizures, lots of different things are going on. I just want to highlight that sometimes you can see increased heart rates. You can see the fact that your lungs aren't working quite as well. If it's very prolonged, sometimes your sugar levels can fall. Sometimes, if it's going on for a very prolonged time and it's been convulsive, sometimes your core body temperature can go up. And sometimes you can start to see injury to muscle, and that sometimes can injure your kidneys. So a lot of different problems that can arise if you're dealing with prolonged seizures, particularly if they're convulsive, but even if they're not. So to that end, I just want to mention that sometimes we do notice that oxygen levels fall. And this is something we often hear, that my child stopped breathing while they were having a seizure. And that's very disturbing for anybody, physicians included. What we see of children who are monitored in an epilepsy monitoring unit, either experiencing a full body convulsion or one of those more milder, say, staring seizures not fully there, about a quarter experience low oxygen levels. As we mentioned, the risk factors were a little bit more likely if they were full body. If they lasted a long time, more likely to have low oxygen levels, and also in the case of people who were coming off of their anticonvulsants. We sometimes do that in the monitoring unit. Sometimes we do that very rapidly, so that can be a trigger. So it's almost like we're stopping their medicines abruptly. So there's some limited evidence that simple repositioning goes a long way. For those of you who've had first aid, you know about the ABCs. The first A, or the A is airway. Sometimes people who are having seizures, you know, they neck dropped, head off to the side, that airway is closed off. So sometimes simple repositioning, getting that airway open, that neck extended, might help alleviate some of the issues with the low oxygen level. And then here's that off-label use. There's some anecdotal evidence that says some compounds, the SSRIs, these are things like your Prozac and your other venlafaxine, can also blunt that lower level. Now that's something, once again, to talk about with your provider, and they will say that there's no solid evidence of that, but sometimes in some patients who've had fairly dramatic issues with that, I do sometimes recommend that. Now that's not for everybody. There's certainly side effects to be considered with that you also have to be aware of, but I just wanted to mention that. Now, as far as management of status epilepticus, this is really based on an expert consensus and protocols that have been worked out over decades. But bottom line, the earlier we treat, the more likely we can stop it. So first line for us is going to be a class of medications that we call the benzodiazepines. I hope everyone, because I'm assuming everyone here has some experience with seizures, that you have your rescue medication available. And I really want to focus on the out-of-hospital issue here. Lots of different versions. We have things like Valium, known as diazepam. You can be given rectally, usually a benefit seen in 2 to 5 minutes. My colleagues and I tend to prefer to use something called clonazepam, also known as Klonopin, comes in the form of an oral disintegrating tablet. Other people have talked about using a medicine called midazolam or Versed, either given in the nose, in the cheek, or even given intramuscularly. In the hospital, we tend to use lorazepam versus or diazepam. There are reasons why we tend to prefer lorazepam over diazepam, but I'm not really going to get into those issues. I will mention to you that there was a study actually looking at the benefit of intramuscular midazolam using a special auto-injector that the EMTs had versus IV lorazepam. They were trying to see whether or not one was less beneficial than the other. Obviously, lorazepam is our standard, but they wanted to make sure that midazolam was no less effective. And they found the answer is that it wasn't. And that's really kind of important, reasonable, just because they found that their conclusion was the fact that they were able to administer this medicine IM, so needle, boom, done, versus where's my IV, let me put on a tourniquet, let me get access, let me get my medicine, let me draw it up, let me, that they found that the intramuscular route was no less effective. So what I kind of take away from that is, time matters, and the sooner you do it, the better. Other routes of midazolam administration were not tested, so they didn't put any in the nose, they didn't put any in the cheek. They didn't test some of the other versions, like the rectal diastat. They weren't testing the oral clonazepam. But the assumption being that they are probably just as rapid and just as effective. This is the diastat for those who haven't seen it. This is the rectal version. So, as far as status epilepticus managed in the hospital, and even for you, the ABCs is something that we all do: airway, breathing, and as far as our cardiac function. If you're having a seizure, we're going to give our benzodiazepine, and once again, if you are involving medical providers, then they may proceed with IV establishment or an intraosseous establishment. So for people we can't get IV access and we need to give them other medicines, sometimes particularly in kids, we will go into the bone directly. Then, depending on how difficult it is to control the epilepsy in the hospital, we may pursue other studies. This may mean that we need to get EEGs urgently. It may mean that we need to do evaluations of the brain with a CAT scan just to make sure there's not too much pressure on the brain, there's not any bleeding, there's not some sort of trauma. If there's a concern about infection, then we may have to do a lumbar puncture, and also chemistries, because sometimes if your chemistries are off, that too can lead to seizures. If we are still having difficulty controlling seizures, then we sometimes have to advance our game and go to much stronger therapies and really kind of drive the brain to a quiet state. And that's what we call the burst suppression pattern, or sometimes induced coma. So, just to conclude, because I too have, I think, in my final lap, risk factors for long seizures, particularly young age in children, illnesses and missed doses of medication, which probably explains when you come to see your neurologist, they're always asking, how are you taking your medicines? And what I would also say is for those who have a history of seizures, you should always have rescue medication available. So, adherence to seizure first aid, where we're talking about the ABCs, might be enough to kind of mitigate some of the hypoxemia. And then as far as your rescue medication, whatever that may be, whether it's the diastat, whether it's your clonazepam, you want to use that for seizures lasting more than 3 to 5 minutes, because I pointed out to you, most seizures don't last that long. So if it's lasting that long, we should be a little concerned. But at any time, if you have concerns, you always contact 911. But certainly, if you use your rescue medication and the seizure is still going on, you definitely need to call 911. Okay? So I just would direct you once again to different resources. A good one to know about is epilepsy.com, which is the website for the Epilepsy Foundation of America. You can read more there about seizure first aid and safety. I always often realize that there are others in the family who may not be here, and they're asking all these questions that you may not know the answer to. So I always tell families, send them here. They can read a little bit more for themselves about seizure first aid and safety. And then you can also get things like seizure action plans, because it's also nice for the schools to have some of that rescue medication around, because the kids spend a lot of time at school, and it's good that they have that available for them. So you can get that form also off from the Epilepsy Foundation website as well. Okay? I think that's it. That's it. No, thank you. So.
Seizure first aid,
Mm-hmm.
how do you open the airway? Put the
Mm-hmm. So the question was, how do you, with regards to seizure first aid, how do you open the airway? So one thing, we don't stick things in the mouth. Never stick things in the mouth. So really, seizure first aid, when we talk about airway, it's really about opening up that airway. So, one of the things that we do is, one, to kind of get the people up on their back and get this neck long, extended, chin up, because what that does is it kind of creates a nice long passageway here. So we're talking about someone who's having a full body seizure, they're on their side. You don't want their chin dropped. It's really about keeping that chin extended, okay, because that's going to go a long way. Just by doing that, you're going to create a nice open pathway for air to flow, and it's not as much resistance. So sometimes simple maneuvers like that may be enough. Yes.
Are mortality rates different for kids who have ESIS?
Yeah.
During sleep, is that changing?
So the question is, are mortality rates different for things like ESIS? And, ESIS is a very unusual entity. There's a lot of disagreement about how we define it exactly or not. But just for everyone, so electrical status epilepticus in sleep is something that was probably reported maybe 50 years ago for the first time. And it's this discovery that when people go to sleep, their EEG takes on a pattern that looks a lot like a status epilepticus pattern on EEG. Now, you wake them up, for the most part, they're fine. How do we typically know about it? Well, usually your level of suspicion is raised when someone presents with new, unusual neurological symptoms. Sometimes it may be, my child stopped speaking. That's a very kind of classic description, like they're perfectly healthy, developing well, normal, just mute. And, there's not some other psychological reason. And so that's one of the issues we might say, well, you need to go to the hospital. We need to get an overnight EEG to see that. Another instance that sometimes is reported are people who have new onset, unexplained weakness. That you may sometimes see that. So this is not something that really is going to be associated with the high mortality, because, as I said, this is happening overnight, but you wake the kids up, there's not really anything to see much different about them. But it's something that when you do treat that pattern, sometimes those other neurological issues get better. So.
We talk about seizures being worse during a fever illness.
Mhm.
And my question is about sleep as well. How do you monitor at night?
This, I think, is probably the biggest concern families have, and I don't have a good answer for you. I think there are several devices around that have not been validated, as Dr. Kerr was alluding to, in a scientifically sound way to say that these are effective. I know people are now using trackers and using apps on devices, things like that. Some families have told me they sometimes have monitors in their room. Unfortunately, epilepsy management really kind of depends on the information that you bring to us. So if you're not seeing seizures, then we're going to say, well, good. Because as Dr. Kerrigan kind of alluded to, I don't really have a test that measures the level of seizure control. So it really is kind of a level of suspicion and concern. Typically, when kids do have seizures in the context of illness, it tends to be at the beginning of the illness, so sometimes you don't even know they're sick. And then the seizures start popping up. So I don't have a great solution to that problem. So, yes?
You talked about, you mentioned chemistries as
Mhm.
far as, what do you, in the ICU situation, or what do you monitor?
So, once again, that's an uncommon reason why people sometimes have seizures. And for most people with epilepsy, the chemistries are completely normal. So it's not something we typically manage. But let's say you had someone who had underlying kidney problems. The kidneys are something that really kind of help regulate, one of the organs that really help regulate kidneys. So let's say someone who had that sort of problem came in with a prolonged seizure. That certainly would be something that we would want to investigate to make sure that those were normal, because if they were not normal, then the treatment in that situation would be, I need to correct the chemistries, and that may very well contract the seizure control. Something we see sometimes in babies, little babies, sometimes they may have very low calcium levels, and that's a very well-known pediatric issue, hypocalcemic seizures in babies, and they really will have seizure, turn on EEG, they are having seizure. The treatment is not to put them on seizure medicines. The treatment is you need to correct that underlying calcium problem, and that will correct their seizures. So, yes, ma'am. Mm-hmm. That's another kind of unusual episode. The question is someone who has a condition called epileptic spasm, which is an unusual, rare type of epilepsy syndrome that we typically see in children less than 12 months of age. They have a very characteristic type of seizure. So the difference, with spasms versus some of these other seizure types is that the spasms themselves, the actual seizure itself is usually very brief. We're talking like maybe a second or two. So it's not a continuous seizure going on for minutes, many, many minutes. Now, what can happen with spasms is sometimes those seizures can cluster. So what that means, they have a spasm, and they may be fine for 10, 15 seconds, a minute, and they have another spasm. And for some people, they sometimes can have clusters, sometimes even hundreds of seizures in a cluster. So I would not treat that in the same sort of urgency as I would with a continuous seizure, certainly a generalized convulsive seizure. But I would, for my families who have infantile spasms, I do say, look, if you had a cluster of seizures that's been going for a prolonged period of time, I would still use the medication to try and avoid it. But they're not going to have quite the same sort of derangements that, say, a full-body seizure would have. Okay? All right. Anything else? So I think it's about time for the break, I think.
Great. Thank you, Corwin. One of the things that's kind of fun for us is that besides just being up here at the podium, we get to interact with you guys a little bit. And so I want to just make sure that as we do our break, basically the speakers are available to you guys in terms of asking questions. So Dr. Williams, you've met. Dr. Maris is back here. Marika, can you raise your hand there? So if you have questions that relate to the realm of neuropsychology and learning and memory, Dr. Maris is your expert. And then Dr. Adelson is sitting over here. David, if you can raise your hand. And if you had, Dr. Adelson will be speaking later about neurosurgical treatment for seizures and obviously is a neurosurgeon. So if you have questions that relate in that area, Dr. Adelson's over here available to speak. So let's go ahead and take our break. We are pretty much on time. Let's reconvene in 17 minutes, which will be at 10:55. 10:55. 10:55, yes. Okay, people, why don't we go ahead and resume? Hopefully everybody had a chance to get a little bit of something to eat or a beverage of some sort. It is my pleasure to introduce Marika Maris, now Marika Maris Clark, who is one of our neuropsychology faculty here at PCH, Barrow at PCH. Dr. Maris trained with us during her fellowship and has now stayed on as a member of the faculty, and she has a particular interest in the neuropsychology of epilepsy, which is to say that she's a PhD doctor who really specializes in how the brain works at a higher cognitive functioning in terms of learning and memory and things like that. So she's going to speak to us today about learning and memory as it relates to epilepsy and as it relates to the things that we treat it with. So I'm glad that you're here.
Thank you. I'm glad to be here. Can you hear me? All right, great. So thank you for the introduction. These are our objectives, but let me tell you just a little bit more about what is a pediatric neuropsychologist and kind of why I'm here to talk to you guys and how I can be of help. So we are licensed psychologists who have specialized training in human development across the lifespan. Because I have pediatric before the title, I have specialized training in child development. But then on top of it, how the brain develops and how different neurological conditions and brain abnormalities impact thinking, learning, behavior, emotions. And all of the things that I do are not medical in nature. I'm not sticking, poking, anything like that. I'm not physically examining children. I'm having them do standardized assessments and then comparing their performances on standardized assessments of different kind of cognitive functions, so things like IQ, language, memory, attention, visual, perceptual functions. I'm comparing their scores with their age-matched peers, grade-matched peers, but then also looking at their scores and their performances and comparing it with children who have similar types of neurological conditions. What do we do with this? We then kind of create a neurocognitive profile or explain it to you as parents and loved ones, kind of what their strengths are. So your child has an average IQ and a particular strength in language functioning and some weaknesses also. And I help to relate that to maybe what you're seeing at home or at school if there are any difficulties, but then also help to use those strengths or help explain to you and give you ideas on how to use the strengths in their profiles to accommodate for weaknesses. Other things that pediatric neuropsychologists do is we make academic recommendations. So we can't set up we can't set up special education in schools, but we can certainly talk about that it's needed and make specific recommendations on how to use that neurocognitive profile to best help your child learn. And then we also diagnose, or because we are psychologists also, we also help to diagnose or understand or help you understand some of the behavioral and emotional problems, make recommendations there, and then give feedback to the medical team so that they can have kind of a fuller understanding of the child's abilities. So yes, your child is having kind of the neurocognitive impacts that are typically associated with their type of epilepsy, so that the medical provider is aware of that. Okay, so what do parents say children with epilepsy have difficulties with? And it's important to note that this sample was a sample of parents, and a rather large sample, but a sample of parents who were being seen through a neurology department. So the child's epilepsy was managed through the neurology department and not through a pediatrician or something like that. So there is the suggestion that perhaps the sample is skewed towards a more difficult type of epilepsy. And these were across epilepsy groups. So children from who had all sorts of different types of epilepsies. So 100% of the parents who responded to this said, yes, my child has some sort of cognitive or learning difficulties. And if you look at kind of the top heavy hitters, they talked about learning difficulties. So things like, my child seemed like they learned something, but now they're not really able to put it down on paper the same way, or it seems like they're not learning the way they used to. Attention difficulties, so my child's impulsive or hyperactive, but also it seems like I'll tell them to do a couple of things, and by the time they walk out the door, they have to come back in and say, Mom, what'd you say? Academic difficulties are just not performing well in school, kind of slowness, and then memory difficulties. So 50% of that sample, 100% of them said something's going on. 50% had learning, attention, academic, slowness, memory, or above. And those are the things that I'm going to be focusing on. I'm not going to be focusing on the language difficulties and the behavioral problems as much. Also, there's a study that looked at what parents are reporting to their neurologists or their doctors, and then in turn what those neurologists and doctors are referring those children to us for, and it was typically attention and memory difficulties. So that's why I was going to focus on it. Okay, so I understand, you all understand, but it bears repeating that epilepsy is not a unitary condition, and that when I'm talking about neurocognitive difficulties associated with epilepsy, we're talking about many different types of conditions. So similarly, there isn't a single neurocognitive profile that's associated with epilepsy. So I may be talking about what the findings show, and it might look very different than your child. And I think Dr. Kerrigan, as well as Dr. Williams, pointed out that we do understand that your child's an individual who has their own strengths and weaknesses, but I'm just going to be presenting kind of the data across the board on epilepsy. And across the board, just like how parents were reporting, 100% of parents were reporting, yeah, there's something going on neurocognitively or cognitively or behaviorally, childhood epilepsy is associated with neurocognitive weaknesses, and many children demonstrate some sort of learning problem. That doesn't mean that children with epilepsy don't have normal IQ. Most children with epilepsy do have normal IQ. with that said, 50% of them meet criteria or have some sort of learning difficulty or neurocognitive deficit that can be kind of diagnosable. So something like an ADHD or a learning problem or a memory problem that is significantly lower than their overall intellectual functioning. In this kind of broad-based sweeping view, children with refractory epilepsy, so they're on multiple medications, but they're still having seizures, 33% of them, or a third of them, receive special education services in the school. So epilepsy comorbidities, so this is how many children have other diagnosable neurodevelopmental conditions, and I'll be talking about neurodevelopmental disorders. But what we see is that we're starting to think of epilepsy, or certainly in the neuropsych world, we've shifted epilepsy to a neurodevelopmental condition, and because epilepsy is a neurodevelopmental condition and neurodevelopmental conditions tend to go hand in hand, we see that a lot of kids also have co-occurring developmental delay, ADHD, and learning disabilities. And oftentimes what we found was that these diagnoses and difficulties predated the onset of seizure. So at any given moment when we kind of tested the cohort or the group of kids who had epilepsy, 51% of them, so half of them, qualified or were diagnosed with a developmental delay at some point. We compare this to 1 to 5% of the kind of typical U.S. population receives the diagnosis of a developmental delay. 40% of kids with epilepsy, oftentimes the ADHD even predated the onset of seizures, have both diagnoses, whereas ADHD in the kind of general U.S. population is 5%. And over half of kids with epilepsy have some sort of learning disability. And ADHD, language problems, reading difficulties, math difficulties are all lumped into this, comparing that with 2 to 10% of the U.S. population. So the data kind of points us in the direction that epilepsy is associated with neurocognitive difficulties. Okay, hold on. Okay. So previously, it was thought that the neurocognitive problems, the learning problems, the behavioral problems, the emotional problems that a lot of parents see, again, that 100% of that sample, were consequences of the seizures or related to seizure variables. So the actual seizures themselves and the uncontrolled activity in the brain, or the frequency of seizures, or the treatments and medications. But as I said earlier, there's quite a bit of evidence to show that these neurocognitive difficulties in many kids predated the onset of the seizures. So we now see the neurocognitive problems that are associated with epilepsy in kind of a multifactorial way. So everyone, and it's kind of well documented that there are absolutely risk factors associated with having uncontrolled seizures and having multiple medications on how the child functions neurocognitively. But there's also the understanding that the same underlying mechanism that caused epilepsy also causes some neurodevelopmental delays. So we've now kind of shifted, certainly in the neuropsych view, to a neurodevelopmental model of pediatric epilepsy. And the neurodevelopmental disorders, again, from my perspective, or the neuropsych perspective, is that something genetic, acquired, caused the development of the central nervous system to be abnormal or not typical. That abnormality in the development of the central nervous system, so the brain, is responsible for brain dysfunction that started in childhood. So from, let's say, a medical perspective, that brain dysfunction is evidenced by seizure activity. from a neuropsych perspective, that brain dysfunction is characterized by things like those developmental delays and the different neurocognitive weaknesses and learning problems. In the psychiatric educational community, there are a group of neurodevelopmental disorders that we frequently diagnose as a result of neurocognitive testing. And those include intellectual disabilities, language disorders, ADHD, tic disorders, and learning disabilities. And typically, research has shown that neurodevelopmental disorders co-occur. We now consider epilepsy a neurodevelopmental disorder. So we are oftentimes looking for if the child meets criteria for any of these other neurodevelopmental disorders. Okay. With that said, there is no question that there are kind of epilepsy-related cognitive risk factors that also impact the way the child functions neurocognitively. So there are things like specific EEG abnormalities, positive signs on neuroimaging, as Dr. Kerrigan was talking about, and different epileptic syndromes that are associated with a deteriorating course of neurocognitive functioning. There's also kind of poor seizure control, status epilepticus, stuff like that. But for the vast majority of the neurodevelopmental epilepsies, the difficulties that we see in the children with academic learning, stuff like that, is part of the underlying shared mechanism that caused the seizures as well. Other cognitive risk factors, there are medication-related risk factors. I will talk about that, but I'm going to emphasize it now and then again, that those medication impacts on neurocognitive functioning are frequently modest, and the risk associated with uncontrolled seizures is significantly greater than those that are associated with medications. With that said, medications do impact the attention and the executive functions, which we'll talk about, as well as fine motor speed. And we see that medications like polypharmacy, multiple AEDs, higher doses, or kind of rapidly going from one dose to another are more typically associated with some of these cognitive impacts. Okay, so we'll review some of the typical neurocognitive profiles. So this was a large-scale study for the degree of research that was done. The numbers aren't that huge when you actually look at it, but considering what they did with it, it's a pretty good study. And this is looking at children who don't have signs on neuroimaging, so there's not a specific spot that you can point to on MRI that says, oh, okay, this is the problem, we need to take this part out or whatnot. So these were kids who had normal neuroimaging. Their neurological exams were typically normal, so they didn't have CP or any of these kind of focal signs, and they were attending regular schools. And the analyses broke these kids up, or broke them up in two different ways. So one, they kind of lumped together the kids who had generalized epilepsies and compared them with the performances of kids who had localization-related epilepsy, and compared those groups to controls, so kids who don't have epilepsy. And then they also broke down and looked at specific diagnostic subsyndromes. And Beck's, absence, juvenile myoclonic, and the focal idiopathic localized related epilepsies. And what's important about the focal ones is that it was epilepsies that were originating from multiple different parts of the brain. So it wasn't just kids who had seizures in one part of the brain. It was one kid had seizures, let's say, in the temporal lobes, the other kid had frontal seizures. So it was a mixed bag. Okay, so this is a busy slide, and I think it needs to be described a little bit. So if you look, here's the zero marks. That's important because this is z-scores. So 0 is kind of your dead average, okay? Anything to the, well, your left, to the left is less than average. But with that said, it's all within the average range until you get to 1, okay? So this is -1, this is -1. From 0 to -1 is still within the average range. Does that make sense? Okay. So what we learn from this is that this is kind of large groupings of kids with generalized as well as localization-related epilepsy, and their neurocognitive functioning is very similar to normal controls in that they're broadly average. Okay, we expect that most kids are average. That's kind of the definition of average, or within the average range. But there are some areas in which both epilepsies have difficulty, and those are the orange ones at the bottom there, that's fine motor functioning, and the different colored blues are the arithmetic as well as attention executive functions, which we're going to talk about quite a bit. So even though there are absolutely differences that you can see between those two groups, both of the groups were more similar to each other than they were to normal controls. This is looking specifically at seizure diagnoses. And here, again, for the most part, children were within the kind of broadly average range, but if you looked at kind of juvenile myoclonic epilepsy, they had the most difficulty in arithmetic or mental calculations and fine motor functions. Absence seizures, they had those same difficulties, but then they, in addition, had difficulties with attention, response inhibition, the executive functions. Beck's, that nothing was as a group outside of the normal range. They were all kind of within that average range, but they did show that relative to their other, to the rest of their neurocognitive profile, they did have some difficulty in fine motor functions. And the non-Beck's idiopathic localized related epilepsies had difficulties with fine motor functions as well as the executive functions. Okay, so let's talk specifically about attention, executive functioning, and memory, since that's what parents are most frequently reporting difficulties with, and that's what they're telling neurologists, and that's why kids are getting sent to us. Okay, so when I use the term executive functions, it is an umbrella term for a group of cognitive processes that allows us to self-regulate across time. It's a bunch of different skills that work together to make us human and make us able to set a goal and do it and behave appropriately and understand the consequences of our behavior and be appropriate in different settings. The executive functions are necessary for independent, purposeful, goal-directed activity. And as I said, there's a lot of them. And we see them in different ways, or we talk about them differently, but I think that this breakdown is the most helpful for parents, and this is typically how I explain it to parents. The executive functions have kind of two major components. There's the social emotional components and the cognitive components. I'll go over the cognitive and then we'll talk about the social emotional. So the cognitive, I have bolded regulation of attention and alternating attention. So even though we think of attention as its own thing, it's part of the executive functions. And without focused attention and the ability to regulate our attention, so what does that mean? That means that I can continue to listen to my teacher even though something cool just went by the window. That's being able to kind of focus my attention, right? So without that ability, so many of the other executive functions are not possible, okay? So the other one's working memory. So you tell me something, so you give me a phone number, and I'm able to rehearse it and remember it while I'm finding a pen and then writing it down. So working memory is oftentimes a difficulty that parents will describe like, I told him, go upstairs, put your shoes on, and put your shirt in the hamper. And he came down just with his shoes on and looked at me confused. That's kind of a working memory type of thing. Planning, organizing, monitoring. So monitoring is you're going about doing something and you realize, oh, this isn't working, I need to do something else. Kids who have difficulties with executive functions kind of keep on chugging and might not notice that their strategy isn't the most effective. Cognitive flexibility is kind of being able to multitask and shift. And what I'll talk about next is that we don't expect a 5-year-old to have all of these. These are things that start in infancy and actually develop well into our 30s. So, for example, think of a beautiful example of executive functions is understanding consequences for your behavior. So think about how you drove at 16, think about how you drove at 20, and think about how you drive at 35. It shows that we really do continue to develop those across time. We think through things more and can kind of assess situations better. Okay. Oh, and processing speed is another one of the executive functions. So that is, I'll hear parents kind of describe it as a delay. The child seems slower. You say something, and then there's a 2-count pause, and then it comes out. The child comprehended it just fine. It just took a little bit of a pause. That's one of the executive functions also. And actually, a slowed processing speed can oftentimes look like inattention because everybody kind of moved on already, and then your child's responding. So it's not that they weren't paying attention, it's just that they were taking a second. Those cognitive processes also impact social and emotional functioning. So the ability to regulate your emotions, again, we see how this kind of gets better and develops across time. A 3-year-old reacts very differently to being told no than a 10-year-old, than a 30-year-old. We get better at it. We're able to control ourselves better and control ourselves in the appropriate situation. Impulse control and delayed gratification. We would never expect a 5-year-old to understand that they need to study every day to get ready for finals at the end of the semester. But we do expect that of a 20-year-old. So the ability to not do the fun thing or the thing that you want to do in an effort to better yourself and get a long-term goal, and anticipating consequences. We often see the cognitive executive functions, and that can bring a child in because, oh, they're not learning in school and stuff like that. But the behavioral problems that are also being seen at home are actually related to these difficulties. So it's not that the kid's defiant or whatnot, it's that they're literally having difficulty inhibiting their impulses. Okay. So I alluded to this, that the development of executive functions start at birth and then kind of continue to work through. Okay. The executive functions in epilepsy, so over 50% of children diagnosed with epilepsy have significant deficits in attention and the executive functions. Generalized epilepsy have have deficits that are more associated with working memory, response inhibition, and some of the multitasking issues. Children who have specific focal epilepsy have larger deficits in working memory. So when your executive functions are impaired, what can you not do? You can not inhibit task-irrelevant behavior. So that's my fancy way of saying I'm listening to the teacher, but something cool goes by. I have to say, okay, no, don't look at the cool thing, or don't tell my friend about the cool thing. Keep paying attention. Executing goal-directed responses, problem-solving skills or executive functions, Being sensitive to performance feedback, so the child that you're telling them that's not working, that problem-solving strategy is not working, and they're continuing to do the same problem-solving strategy, even though you're giving them that feedback. And having kind of an internal direction of behavior or motivation. I oftentimes hear parents with epilepsy say, he just seems unmotivated. He just seems like he doesn't, or she just seems like she doesn't have the desire or isn't able to kind of start things out or start doing their homework or continue to be motivated across time. That's likely a sign of an executive dysfunction. Memory. So memory is a complex construct. First, we have to attend to the information to even have a shot at learning it. So kids who have inattention oftentimes look like they have memory problems. But when we fix the attention, the memory looks better. Problems with information. So a child that has an attention problem has the most trouble when the information is said once, not repeated, and kind of quickly given. When children who just have attention issues have information presented multiple times to them, they don't have problems with learning and memory. So after we've attended to the information, we need to be able to kind of keep it in our brain sketch pad while we're learning it and kind of putting it where it needs to be. So children with working memory issues tend to look like they have problems with memory. Then the brain puts the information somewhere, and the other part of memory that's huge is that we need to be able to pull it out and let people know that we know it at an appropriate time. So sometimes with children with epilepsy, we see that there are word finding issues, or there's a delay, or they won't be able to just give it to you themselves, but if they have to pick from multiple choices, they can easily do that. There are different types of memory, but I'm short on time, so I'm gonna, okay. Children with epilepsy in general don't, again, across epilepsies, children across epilepsies in general do not have problems remembering information that's contextual. So they don't have problems remembering when you went to Florida and went to Disney World, and they can tell you everything that they love about Frozen and whatever, because episodic memory is, it happened to me, I remember it, it was important, and it's rich in contextual information. Semantic memory is just factual knowledge. And that's the type of stuff where you know that the picture of an apple is an apple. It doesn't have contextual information. On the whole, children with epilepsy, again, all types of epilepsy, don't have deficits in semantic memory skills either. They're able to remember facts. However, when you make it more complex and add what we would consider an executive component or an association component, that's where kids start to have difficulties. For example, and actually, that's the type of memory that you need for school. So association memory is knowing a list, knowing who the discoverers were of a bunch of different places, or explorers, knowing what they explored, and then knowing the years that they explored them. That's not, it's not like knowing what year you went to Disney World, because the child didn't go and explore any of these things. There's no contextual information. It didn't happen to them. But they're needing to know a list of information or needing to know facts and associate it with more facts. It's a higher level academic skill. Or that's a higher level memory skill, and that's the closest type of memory that we use in school. Those are the types of memory that memory problems that children with epilepsy have. Okay. Let's go to the treatment stuff because that's important. Okay, so anti-epileptic medications. So across epilepsies, uncontrolled seizure activity is a much stronger predictor of neurocognitive deficits than all of the AEDs, including polypharmacy. So that's important to know, that if a medication is providing seizure control, and in an uncontrolled, previously uncontrolled situation, but it's causing a bit of slowness, that the bit of slowness causes less neurocognitive deficit than if the child were to continue to have seizures from a neuropsych perspective. The medical perspective, talk to the neurologist. With that said, I absolutely believe every parent that tells me, no, you don't understand, this medication is making him slow, or this medication has caused him to have more memory deficits. One of the reasons why we kind of can't capture this, or we don't have the data to say, okay, yep, this medication's definitely associated with that, is that studies of epileptic medications are kind of inherently difficult to study in kids who have epilepsy, because we can't necessarily take them off of the medication that they need to have for seizure control. So I completely believe you, we all do, but we just don't have the data to necessarily support that one specific medication has a specific impact, except for there are some. So Keppra happens to be one of them, and this study just came out, and I thought it was interesting. So Keppra has good and bad aspects to it. So we oftentimes hear the kind of behavioral challenges that are associated with Keppra. They looked at kind of neuropsych. How does Keppra impact neuropsych? And what they found is that it actually improves focused attention and speed of processing. In turn, though, it also makes children have more difficulty inhibiting those impulsive responses and regulating their emotions. And instead, in some children, it can make them more aggressive, hostile, or nervous. So this is in some children, and it's dose-related and whatnot. But if you are seeing some of the improvements in focused attention or speed of processing time, it could be because of the Keppra. Okay. Topiramate, there's quite a bit of evidence that high doses of topiramate delay reaction time and kind of cause some slowed processing. And this is a graph that shows that. So at baseline, all of the children with epilepsy were kind of at the same point in speed of processing, but then across time, and dependent on the dose, we see that their reaction times got longer and longer. Okay. AEDs and memory. So seizure activity and abnormal epilepsy-related discharges can disrupt the processes of memory. So we have that documented. We know that that can happen. Unfortunately, there is not consistent evidence that medication alone disrupts these processes. And when you control for the impacts of multiple medications and seizure activity, medications alone have not been linked to memory problems in control groups. Okay, quickly, surgical outcomes on memory, and I'm sure Dr. Adelson will talk about this. But when, and I think this is a great group of studies, so they compared pre- and post-surgical. They did neuropsych assessments before surgery and after surgery in a group of kids who had temporal lobe epilepsy. So their seizures were originating from the temporal lobe. It was a mixed bag. It was kids who had seizures on the right-hand side as well as on the left-hand side. And kind of across the board, the only memory declines that they saw were in naming. Why this is particularly important is that the temporal lobes are the part of the brain that are responsible for memory. And one would expect, oh, well, if you're taking that part out, aren't they going to have memory problems? Well, actually, no, because in these kids, the memory problems had already been caused by the seizures. So the area that they were removing was not actually usable working memory tissue. They found slight declines in post-surgical naming abilities. So kids weren't as fast at pulling up the name for a picture. But their episodic memory, their other semantic memories were okay. Most importantly, when those kids who did have naming declines were compared with other kids who didn't have surgery but had the same type of epilepsy, at a later point in time, their naming was the same. So perhaps kind of declines in naming would have happened across time anyway. Okay? Okay, so I talked about this stuff already, and I think I'm short on time, right, Dr. Kerrigan?
You're right there.
I'm right there. Great. So, real quick, you can have a school-based evaluation or a psychoed through the school if you're concerned that your child's having learning problems. They will test academics and IQ, but other than that, they won't be able to go into the same kind of depth and breadth that neuropsych does, so they won't do attention, memory, and whatnot. And although I think there are many kids who would be well served with a psychoed evaluation, not all will be. One of the major distinctions from neuropsych versus psychoed is not only that we test more domains, but also that we're not just reporting scores. We're looking at the underlying neurocognitive ability that resulted in that score. So school might tell you there's a problem with math. Neuropsych will tell you, well, that problem with math is due to an underlying problem processing visual spatial information. Yeah. And these are just different accommodations, but let's go to questions. Any questions? Thank you. Sure.
So, what kind of treatment is there for people with executive function abilities?
Right. So there are stimulant medications, like for ADHD. I'm not a medical doctor. I don't do that. There are also kind of accommodation strategies. So the types of things that I recommend for parents is providing as much structure and scaffolding, and then helping the child to learn those processes that children who are typically developing might learn on their own. So I oftentimes say, like, okay, if you guys are going for a trip or a vacation, make it that you and your child plan together what to pack. So getting them used to thinking through those processes and showing them how you do it. And then also talking through everything and kind of behavioral management strategies. So one, you want to build in that pause if they're impulsive. So whatever you need to do to build that in, but then also helping them to learn skills for organizing and stuff like that. There's a bunch of others. Yes?
I saw you video in the 504.
Yeah.
Curious. If you have a child that's going into, say, a multi-teacher situation, entering junior high, it's already an issue for teachers aware that there might be seizure activity. But with the multiple teachers, even though the 504 is in place, are there accommodations that you could suggest that would support the child, be it giving them written hard copies as opposed to lecturing, or letting the child have recordings? Because there are some, I know with the person I'm thinking of, there are memory blocks. So it's going to be very difficult with multiple teachers and all this new information in junior high without having to have an IEP or a special ed.
Right, and I think at that point, I would agree with lectures beforehand and after and whatnot, but I would also think that an IEP could be warranted, and you might be able to, with neuropsych testing, be able to have resource instruction or resource room time, not because the child needs basic instruction in those skills, but so that things that were covered when the child was having a seizure can be covered again.
Is the school required to address those with the child through the 504? Because I understand there's a law that kind of mandates that.
So if you aren't documenting that there is a deficit in those areas that can occur, they don't have to. Once you have an IEP in place, or if you have someone who says you have to do this, then yes.
So they can accommodate.
Oh yeah, they can accommodate it. Sorry if I didn't answer that. Oh, so I think our wait list is a lot better, and you would have your neurologist or your treating physician just refer you over. So I think it's gotten better. I think we're at like a couple months, 2 maybe. Not too bad. I think we've gotten better, but don't quote me. Okay. Oh. Do we need to stop?
I think let's go ahead and move on.
Okay, thank you. I'm going to take this.
Marika, thank you very much. I think you can all congratulate yourself on your executive functioning as you got here today with a lot of competing stuff going on elsewhere in your life and outside on such a nice day. Our last speaker is Dr. David Adelson. David is the director of the Barrow Neurological Institute at Phoenix Children's Hospital, so he is the big cheese in our neuroscience program. Also the division director for neurosurgery, and also our epilepsy surgeon. And he's going to speak to you today about surgical treatment.
Alrighty. Well, thank you all for being here. It's really actually, I'm quite fortunate to have the opportunity to work with, Jack and Corwin and Maris, really in being able to provide the treatment that we do. I did want to kind of hash a little historical here. Jack and I were actually residents at the same time in UCLA. I won't tell you when that decades were, a few ago. But interestingly enough, a lot of people sort of ask me about surgery and would you recommend it for your child or the like. And actually, my stepson had epilepsy surgery, ended up with a hemispherectomy. And so that's how I had my early exposure. This was while I was still in training. And so now 25 years later, I'm very passionate about surgical epilepsy. I do believe that it is an opportunity in order to not just try to cure the child, but also provide opportunity to be seizure-free and to really add to quality of life. And so it's not just me telling you what the books say. It is from a personal perspective as well. Having said that, I'm going to talk a little bit about the epilepsy surgery in children and try to give you some perspective from the surgery side. So surgical treatment of epilepsy is actually around a lot longer than 60 or 70 years. The first epilepsy surgery was actually in the 1890s. So it has been around for a long, long time. Where we've gotten very good at is identifying where the seizures are coming from. And that really is what kind of truly creates the best outcomes. Most of that has been in adults because we're willing to do surgery on adults much more often than we are on children. But in essence, really, children are the ones that have the greatest potential, not just to be improved by surgical epilepsy, but also then have a lifetime of being able to live without epilepsy, and that's really what our goal is. It is a common neurological disorder, as Dr. Kerrigan has already pointed out, and while seizures in adults is problematic because obviously it impacts on vocation and it impacts on the ability to have certain interactions and social interactions with children, as was pointed out by Dr. Clark now, is that it can impact on memory function or cognitive function and a lot of other things as well. So I'm going to talk a little bit about the different things. We know that intractable seizures lead to a decline in development as well as psychosocially, and we feel that surgery does have creates an opportunity. It's an alternative in many instances to medications for specific reasons, but it's one that also needs to really be considered, particularly when medications fail. So I'm just going to highlight a few things for you, the differences we have between adults and children, some of the evaluation that we do, surgical options, and I'll try to run through these without all the gory detail because I see there are little ones here. Some of the outcomes and then some of the future things that are kind of what we hope to be on the horizon. So classically, we talk about the differences between adults and children. We talk about that adults tend to most often have temporal lobe epilepsy, as Dr. Clark kind of pointed out. They're complex partial seizures and have a very single or very specific area of focus, which is within the temporal lobe, the amygdala, and hippocampus. Children, on the other hand, tend to have much more diffuse seizure types, tend to have things that are not just temporal in origin, but sort of throughout the cortex, and that was based on, as Dr. Kerrigan mentioned, cortical dysplasias and other pathologies. And as a result, it becomes a bit more complex. So actually, I do both children and adults. And when I came here so when I was in Pittsburgh, I did equally about the same number, but since coming here, really focused much more on children. So let's talk a little bit about mortality. So at least for uncontrolled seizures, and we talk about SUDEP, and Dr. Kerrigan sort of mentioned it, but we are concerned about this, what's considered sudden unexplained death of epilepsy, and there's thought to be either through accidents or SUDEP, a high mortality relative to these children. What the causes are still sort of remain in question, but it could be unprovoked seizures or some complex status epilepticus, as Dr. Williams pointed out. It can be due to acute symptoms, due to, so let's say, a fever or illness or something that sets things off. But unfortunately, younger ages are associated with a higher mortality, particularly if they're infants or young toddlers. And so for that reason, with regards to adults, it really depends on the duration that leads to that. And so when we start to think of passing away from, and most people are concerned about, well, if I undergo brain surgery, I'm going to possibly die from that. The reality is that the mortality from epilepsy is much higher than that from surgery in this day and age. Now, in the 1890s, you were really kind of a flip of the coin there, but I'd like to think that in 2016 we've come a bit of a way since then. So, and then as Dr. Clark had pointed out, there's cognitive impairment that can come along with intractable seizures, and we know that once they have intractable seizures or status epilepticus, much higher risk factor for poor outcomes. And there's a number of studies that have shown that throughout the years. So really, what are our goals of epilepsy intervention? And you've heard that today, whether it's medicines or ketogenic diet or other things, the goal is to stop seizures. Clearly, we want to try to prevent, and I should have put in quotes, brain injury, but it's really the interference of normal brain function that seizures cause. So if someone's driving and has a seizure, that has the risk of injuring themselves. But as well, the seizures, we believe, is negatively impacting on brain function. In adults, the goal is to try to improve quality of life, because if you can't drive or you can't do your job, those are going to obviously impact on that. But in children, our goal with early or complete cessation of the seizures is to allow them to develop and to allow them to have a normal life going forward with normal neural development. So what's the goals of surgical intervention? Basically, it's the same exact thing. So our surgery is really just one modality that we try to use in order to stop the seizures for all the same reasons that we use medicines or diet or other things. So we believe that epilepsy surgery is clearly the best option for those that are what we call candidates or qualified, those that could potentially have a cure. And the reason for that is really because resective surgery has decreased mortality, improved quality of life, improved long-term outcomes. Now again, for a specific population of patients where we can identify a seizure focus and stop the seizures from occurring. Not everybody is going to be able to benefit from that, but that's where we then start to get into the discussions of those gray areas where does surgery make sense for particular patients. So having said that, it's really dependent on the seizure type. So if indeed you have a temporal lobe epilepsy with an isolated lesion, that's a case where medicines most likely will not work, surgery will work, and the likelihood of you having an excellent outcome from surgery compared to medicines is much higher. When it becomes more diffuse or some of these other areas, that's where it comes into question, and that's where we start to get into the balance of whether there's a risk-benefit to it. We know that if indeed we can identify a lesion, we can then see something on the imaging that's abnormal, and that's an area that we can target with our treatments, then that's a patient that's going to do very, very well. Those with non-lesional substrates where we don't see what's going on or we don't understand where the seizures are coming from have a much more difficult time for us to get a good seizure control. So what goes on? So Dr. Kerrigan sort of mentioned it in passing, but what we're really trying to do is see where the seizures are coming from. Can we lateralize it to the right or the left side? Can we localize it to the temporal lobe or parietal lobe or frontal lobe or things along those lines. So we first start with an MRI. I can at least honestly say that when I started my training, we had MRIs, so I'm not that old. So having said that, in the MR era, clearly the sequences by which we're able to pick things up, moving from what was a 0.5T now up to 3T, 3 Tesla machines, we're now able to pick up much better resolution, much better detail as to the uniqueness of someone's brain. And then we've also grown on functional imaging. So I was fortunate to work with those who started PET imaging, which is positron emission tomography. And again, we started to look at it and realize that epilepsy is indeed a functional disorder. So it's something going wrong relative to how the brain is functioning. And so these type of functional, tests like SPECT and MR spectroscopy and others really give us a nice picture of what's going on in the brain, how is it functioning, can we identify areas that don't look right. And really our goal when we start to think about surgery is that we take all of that information and put it all together into a decision for our making. So here's a MRI, again, not really particularly unique there, but one would be hard-pressed to sort of figure out the abnormality. We have different sequences. Now you're starting to see that there may indeed be some abnormality right there, for example. You can see a difference from side to side. This is a patient who had seizures coming from their insular area, and again, we can point out different abnormalities where parts of the brain that didn't develop well potentially point us in the direction of where their seizures may be coming from. And then we can use MR spectroscopy. Again, this starts to look at the metabolic structures, so we can start to target different areas of the cortex or areas that we think are abnormal. So this starts to give us maybe a little bit added pieces of the puzzle. And then this is a PET scan, and one can appreciate, and you don't have to be a neurosurgeon to see the difference here, but here looking at in this case, a left temporal hypometabolism. This is looking at how the brain is utilizing glucose, and one can appreciate that that area of the temporal lobe is abnormal. So if we're able to correlate the MR, which is the anatomical study, now with a functional study, now we can make some decisions that this patient would likely benefit from surgery. And then we can now start to marry or cross-reference the functional studies with the anatomical studies. And here you can appreciate here in this one, looking at the PET study overlaid over the MRI, that there's an area there in the parietal lobe that's not functioning well. Now we can start to think, oh, maybe that's the cause of the seizures. And then there's SPECT, and we also used this study here. SPECT is pretty good. We used to use it just sort of between seizures. For example, the PET study is used between seizures. This is where we try to actually target the seizure itself. This is the study that we use between, which is what we call an interictal SPECT. It looks at blood flow. We then do what's called an ictal SPECT, which now shows us that blood flow goes up when the seizure occurs. And then we now have technology where we can subtract them, and then voila, we can see kind of a nice picture of where the seizures are coming from. So these are how we might be able to target areas where there's some, what we consider focal epilepsy. And then sometimes we can add these. Again, this is that sort of subtracted image, and we can cross-correlate it with our MRIs and now pick up the exact location where we should be thinking maybe the seizures are coming from that spot. Well, similarly, you may have heard of MEG, and so MEG is basically marrying what we call magnetic source imaging, or taking electrophysiologic changes in the magnetic field. So people go into the MEG with EEG leads on, try to pick up some of the abnormal electrical activity, again, marry that to the MRI, and then we can start to target areas of potential epileptiform activity. So this was an interesting case. This is a 12-year-old who has this lesion here, but his EEG that he was having in the EEG lab was saying it was coming from the frontal lobe. So now we were kind of like, well, you know, where are we at here? Is indeed the lesion have nothing to do with his seizures? We were getting EEG information that was saying it was frontal. So where do we go? How do we start to make that decision? Well, here was his MEG that seemed to really target that back area. And this was one of the early MEGs that we did. And when we put in electrodes, both frontally and in this area, we indeed found that this was the area that was abnormal. We went in and resected that area, and that patient was seizure-free afterward. So in this particular case, the MEG was very, very useful in targeting for us where the seizures were coming from. And it really did correlate with the lesion. So when we see a lesion, much higher percentage chance that that's going to be the origin of the problem. So then if we get all that information and we sit down as a group, and that's why I'm fortunate to have Doctors Williams, Kerrigan, and the crew, plus the neuropsychologist, the neuroradiologist, and all of those. We all get together and we have a discussion, and we try to take all of that data to decide if indeed we can go right to surgery and take out a particular area. But in those instances where we cannot make a decision because we've got information that's maybe questionable, like I just pointed out in this last example, the frontal lobe versus the parietal lobe. That's a large area that we have to figure out. Well, in those cases, we may go ahead and put in what we call invasive monitoring. So we may put in either surface or depth electrodes, which are inside the head in order for us to be able to pick out directly. So try to put electrodes right in the area of where we think the seizures are coming from. And that's really because we don't have enough data. We're not going to go on a fishing expedition in your child's brain and sort of, kind of hope that that works. We would really like to have as much knowledge and as much confidence that we're doing the right thing. And so invasive monitoring is sort of our next step in that. There are a lot of different methodologies, and for the most part, the acute ones we tend not to use as much in children because, for example, mapping and some of these others, we actually have them awake, so we don't do that in children. But we tend to do extraoperative mapping, so we can put in the electrodes, we can suture everything back up, go to the epilepsy monitoring unit and monitor and see where the seizures are occurring right at that given time. And then we can correlate that when we do the mapping to where are those seizures coming from relative to where their functional areas are, where's the motor areas, where might be language, those kinds of things. Because indeed, part of what we're making decisions on are not just can we cure the seizures, but obviously we don't want to create neurologic deficits if we can avoid it. And if we can find a particular corridor or target or area that avoids that, that's obviously the optimal approach. So I showed you this picture a little earlier, similar type of picture with an insular lesion here. So when we start to decide on a phase 2 strategy, what we're trying to do is target that. So that was a deep lesion. Here's the surface of the brain. And so diagrammatically, we put in electrodes around that lesion and try to pick up where the seizures might be coming. These are depth electrodes that go through the surface of the brain into that area. And then if you were looking at it from the surface, this would sort of be the picture that you might see. So this is just a picture of the brain. I showed you that insular lesion, which is in here, and these are the depth electrodes that we placed around in order for us to try to pick out that seizure focus. And then this is a surface electrodes that we put there right on the surface, and now correlate all of those electrodes in order to try to get that the best picture to be able to kind of see in 3-dimension, where the abnormality is. And then stereo EEG has been around actually for a long, long time. When I was in training, we used to put in depth electrodes, what we called orthogonally, in this manner. We stopped doing that when we started getting better imaging and started using surface electrodes. It's having a little bit of a renaissance. I'm not yet personally completely convinced that it changes anything because they still need multiple surgeries, and you end up taking the electrodes out before having to go back in to go for the seizure focus, versus what I showed you earlier where we have everything exposed. When we come back a week later, we go right to the areas, the numbers, as I see if I can go to the previous one. Here, when we go back a week later, these are numbered. We can target exactly where we want to go right at that second procedure. So again, when you get older, it's kind of like what's old is new and what's new is old, right? You realize you weren't as smart and you have this great idea that someone figured out 100 years ago. So, But having said that, I think that there's a lot to learn in this, and I think with our imaging capability that more of these type of procedures will be done, but in particular patients. And then the surface electrodes I sort of mentioned, and we can use for coverage here. But the nice thing about the surface electrodes is we can stimulate back along them and be able to target, for example, language, which was right in this area. And so when we think about doing a surgery or taking out part of the brain, we want to avoid an area that's functional. So what are our treatment options? There are a number of different surgeries, and there's a whole long list, and this is kind of neurosurgery 101, so get your Mr. Potato Heads out and you can start working on them. But these are the different opportunities and different options that you might speak with your neurologist about as we start to think about surgical interventions. So I'm going to just talk quickly about resective surgeries. You heard about temporal lobe epilepsy, still the most common surgical procedure in adults, but also very common in children. We know that a lot of the history that adults who develop temporal lobe epilepsy is because they had febrile seizures as children and ended up with temporal lobe epilepsy as adults. And so that's really the most common etiology that we see. We know through a number of different, through the years and through a number of different studies that our imaging has really helped to really improve this, so we don't have to do the open procedures, that phase 2 evaluation anymore. And we know that temporal lobe epilepsy surgery is clearly superior to medical therapy. So if you have temporal lobe epilepsy and it's isolated to a single temporal lobe, the chances for cure, quality of life, and neurocognitive outcome are much better with surgery as compared to continued medicines. And this is the reason. This was a study done back in 2001, so it's now about 15 years old, and there was no question, at least in this group, that 58% were seizure-free by the end of the study as compared to only 8% in the medical group. And so, and then, as I mentioned, quality of life, and interestingly enough, also mortality. There was no mortality in the surgical group, and there was one mortality in the medical group. With regards to extratemporal, this is what we see more commonly in children. Again, we have to do the extensive evaluation because, again, we're not trying to do anything willy-nilly. We really want to know where the seizures are coming from, and that's really why this concordance of data to be able to identify the focus and the area is most important. And there are plenty of abnormalities. This is a child who was born with a significant cortical abnormality. This was that subtraction study that I mentioned. Here's that schism. This was a schizencephaly. And here's the surface electrodes and some depths. And when it came right down to it, one can appreciate similar. This was the EEG. Highlighted again, this was the area that was very hot on the SysCom that showed that indeed the seizures were coming from that location. But with an extensive abnormality, we have to do fairly extensive coverage to make sure that there's not any other areas of abnormality. Laser ablative surgery you've seen over the last few years. It's been particularly useful for those patients with hypothalamic hamartomas. It's really kind of become the vogue for that particular pathology with a particular characteristic on imaging. It uses MR guidance for this, and with this we use laser light delivered. Temperature is elevated to the point where it interferes or destroys the tissue, so it's basically a laser ablation from within the tissue itself, and it's monitored in real time using the MRI scan. This is a typical picture of a treatment plan. Here's the electrode that's inserted down to the area of the, in this case, HH. You can see the different temperature ranges that are given when it's heated from within, and then the expectation will be is that it interferes or destroys that tissue or the tracks of that tissue as it's causing the abnormal connections. This is on the more experimental side. This is, and this was not ours, this was from a colleague of mine, but this is looking at an area where they were looking at temporal lobe epilepsy, and so it's now starting to be used for, as I mentioned, this type of focal epilepsies. The difference is that it requires more than one target. You actually have to start to create multiple targets to shape it appropriately so that you can indeed ablate all of that tissue. But I do believe that this is on the horizon and will be beneficial and a valuable adjunct to what we're doing presently. Now, in some cases, unfortunately, we can't find a specific focus like I just pointed out here, and so in these cases, we start to think of other types of methodologies, and so some of these are under what we call disconnective procedures. There's a number of them, and the goal is to disconnect the seizure focus from the rest of the functioning brain, and so that's when we start to look at these, we're not likely to get a cure. What we're likely to do is try to interfere with specific seizure types that require that connectivity, and so that's what we're trying to accomplish. And so there's a number of them. You may have heard of corpus callosotomy, multiple subpial transections, and then cerebral hemispherotomy, what would have originally been the cerebral hemispherectomy. Corpus callosotomy, we divide the fibers between the two hemispheres, and that's because the seizure foci go off almost simultaneously because of the communication between the two sides. So what we're trying to do is just divide those communications. And for the most part, while it rarely produces a seizure-free state, for those patients with drop attacks or atonic seizures, this is a very effective method. Now, the reason that we go to such a drastic measure is because with drop attacks, these are patients without warning will have a seizure, drop to the ground, most often will smash their face, break teeth, multiple things like that, have suffered multiple head traumas. And so in those instances, this type of procedure is much preferred to try to prevent that particular problem. Now, I've seen some of these children, and now I'm going to date myself, that looked, like Joe Frazier or, Trevor Berbick, and they're, how about Rocky from, that was, from the first picture. So, in those instances, clearly this is a much better alternative than having them suffer severe injuries. We go through a very small incision at the top of the head. We're able to target the corpus callosum, and this is what it looks like under the microscope. This is the corpus callosum, these white fibers that communicate the two sides, and then we just basically divide the fibers. This is actually the walls of the ventricle, and so beautiful anatomical picture from the perspective of that it's a very clean, there's no removal of parts of the brain or things like that. This just divides communication between the two sides. As I mentioned, with the cerebral hemispherectomy, historically it was what we called the ultimate focal resection because we took the whole hemisphere out. It was really because, as I mentioned, to stop intractable seizures, because that hemisphere was a bad hemisphere. It was one that was really interfering with the ability to develop. The secondary purpose, obviously, is to allow the hemisphere that was normally formed to be able to grow and develop and take over those qualities. No one would believe it. You can take out half a brain, particularly in a young child, and they will walk again, they will run, they can go to school, all of those different things. And so if the functional hemisphere is relatively normally developed, then it will take over those functions and they will be able to do those activities. And so if, on the other hand, there's abnormalities in the development of that other hemisphere, there may be some challenges. But again, that's part of the discussion that you would have. So there have been techniques that we've changed because the anatomical hemispherectomy was fraught with potential complications. And so what we've been able to do is get smaller and smaller down to the point now where we just do basically a disconnective procedure. So originally a functional hemispherectomy, instead of taking everything out, we just remove the middle, and then that would sort of disconnect everything. And so this was what it used to look like. Here's kind of this missing parts, and this is looking upside down. This is the face over here, and this is the back of the head. And now when we go to a hemispherotomy, we're just making these little small incision, and we're able to create all of the disconnections through a small incision. And in fact, because we can do this much smaller procedure, we can do it in a very young child. And this is one of the children we did a couple of years ago. This was her at about 4 months of age. So in this child, the left hemisphere was completely abnormal, and she's now about 1.5 years out and is developing and smiling and playing and is seizure-free. So again, our ability to minimize our techniques have allowed us to really offer this to younger and younger children. Just to move on to neuromodulation, again, there's a number of different devices out there. Most of you have heard of vagal nerve stimulation, and again, that's been around for now over 20 years, or close to 20 years, excuse me, and indeed has really been our mainstay. And then there are a number of other areas that I believe are on the horizon for intractable epilepsy and that you'll see much more of over the next few years. With regards to VNS, one of the things that I say, maybe Dr. Williams would disagree with me, but it is not surgery. It is really an implantable medical device, and that's really what we're trying to enhance. There is no taking out of the brain. There's no interfering with fiber tracts or anything like that. What it is, it's basically a brain pacemaker, and with it, the surgeon basically is just a tech on this. We put it in, and it really then depends on your neurologist, your epileptologist, to change the dosage, which is the intensity of the stimulation, as well as the frequency. How often is it going off in order to give you those stimulations? We do consider it another medication, and if indeed there's not a way to cure the seizures or there's no other best option, then we do recommend the vagal nerve stimulator because indeed it has the better potential than if you go to further medications. And again, it's protocol driven based on the seizure type as well as the different response to it. It's really for any child who has medically intractable seizures with greater than 2 anti-epileptic medications, and you already saw from Dr. Kerrigan, once you get beyond 2, your percentage response is going to go markedly down. We most often use it when resection or other types of procedures are not an option. It's really, unfortunately, a palliative procedure. It's not curative, but at least in some patients, small percentage that they can get a significant response where they can lower their medicines or even be off medicines completely. There's a lot of literature out there, and some is conflicting, but I basically say that about a third of patients will get a significant response, a third of patients will get a so-so response, and a third of patients it won't make a difference at all. And there are a number of different protocols that we use in order to do this, and oftentimes it's not a single therapy, it's a combination. So it's vagal nerve stimulation with medication and or maybe with a corpus callosotomy or some other procedure. So generally we implant it. It's for us a 45-minute procedure. It's basically implanting a generator underneath, just below the collarbone, and electrodes around the vagus nerve, which is in the neck. And we go on the left side for a number of different reasons. I wrote 1 to 2 hours, mostly because the anesthesia is actually almost longer than the surgery itself. It's an outpatient procedure, so you go home the same day, usually within about 2 hours of the procedure, and we consider it low risk and probably lower risk than some of the medications. These are the different devices that we've used over the last few years, and the more recent one is the 106, which is a closed-loop system, which I'll explain in just a sec. But ultimately, it's really about being able to capture when someone is having a seizure and then giving an extra stimulus during that time. This is a little bit of an older slide, but this was my experience in Pennsylvania. We had put in almost 500 over that period. It can cause some voice alteration when the stimulation goes off, but usually it'll go, so a patient will be talking to you, it'll go off, and they'll get a little bit of a whisper, and it'll be hard to hear them. And then when it turns off, their voice goes back to normal. That can happen in about a third of patients, and usually we can adjust the intensity to try to prevent that. What we were really concerned about was vocal cord paresis. We've actually lowered this down to about 1% now. It usually resolves within about a month. Only had one case in which it lasted greater than 6 months. Infection is about 2%, and most of those are really just superficial, but we have had to explant 2 patients in order to, because of the infection was so bad. The most important is letting that heal. Unfortunately, in children who have drooling issues or problems with that, or who have psychiatric or behavioral issues and can't leave it alone, that the incision can get infected, and then that can get to the device itself. Just the future, as I mentioned, sort of this closed-loop system where the new 106 is now starting to be able to capture heart rate when there's a seizure and try to give an extra stimulus. There are a number of other closed-loop systems that are in development and a number of different other strategies that I believe you'll see. And again, we're investigating a number of these and hope to have them out and available for people in the near future. So just in summary, we know that epilepsy, as has already been pointed out by the other speakers, significantly impacts quality of life, vocation, those kinds of things. We also know that in children it can affect their development, and so that's why we tend to be on the more aggressive side for kids. There's no question that in select cases that outcomes from surgery are superior to failed medical therapy, as Dr. Clark had pointed out, not just from the sense of seizure control, but also in development and neurocognition, naming, those kinds of things. And our goal, whether it be with surgery or with medicines or with diet or with whatever, our goal is to try to get good seizure control so we allow for the best development. I wanted to just close with this particular story. This was a young woman, Rachel, allowed me to use this slide. She came to me when she was actually about 15, 16 years of age. She had temporal lobe epilepsy. She had a clear abnormality on her right temporal lobe on the MRI. She had a functional abnormality, and she came because she wanted to explore surgery. The parents were not so confident about surgery, and so they elected to say no, and that was kind of it. And I didn't see her again till literally a month after she turned 18, where she walked in and said she wanted surgery. She ended up with surgery, and you can see here in June of '08, and then she ran a marathon a couple months later and has been seizure-free. She's actually a teacher in special ed, so really a fantastic story. And I would be remiss in saying that the team here is just fantastic to work with. We're not perfect, and so I would, say, expect that we'll at least do our best to try to accommodate everybody and to help you understand what's going on with your child and what we can do best to treat them. And really couldn't do it without the group that's here. Really, I'm just a cog in the wheel with this really a wonderful group of physicians and psychologists, neuropsychologists, and the like. So with that, thank you. And if you want to get a hold of us, we're on, obviously on the web, where we try to post as much information as possible, but on Facebook, Twitter, and in fact, Molly in the back there has got a running feed on Twitter if you wanted to get a rehash of everything we talked about today. So thank you very much, and I'll take some questions.